Global Health Alliance and the chairman of the organizing committee for the GHA OneWorld Summit. We are on day two of the GHA OneWorld Summit, which is on the new clinical era reshaping the global health. We heard all our experts and key opinion leaders on day one on how artificial intelligence and blockchains and other resources are playing a very important role in shaping the global health. But we have got real clinicians, real gurus of medicine, cardiology, diabetes, all non-communicable diseases from around the world joining us today to discuss the challenges ahead, especially in the global health. And on that note, we are very happy and pleased to introduce to you our first speaker, Dr. Randeep Guleria, who is the current chairman of the Internal Medicine, Respiratory and Sleep Medicine at Medanta Group of Hospitals. Dr. Randeep Guleria does not need any introduction in the world of pulmonology and respiratory medicine. He is a former director of All India Institute of Medical Sciences, AIIMS, New Delhi, a Padam Shri awardee, and also he has pioneered several initiatives for the well-being of people of India and the Indian subcontinent, especially apart from making global contributions, especially in respiratory disorders. He played a very important role during the COVID-19 government's response, and through which hundreds and thousands of lives were saved in India. So thank you so much, Dr. Galera, for joining us all the way from India and making time for this event. Obviously, the topic that we had selected for you was on global health security facing the next pandemic threat. So, but in the news, we have been seeing in the last few weeks, especially that Delhi has hit very high on the AQI index. So maybe we would obviously start with your topic on discussing the next pandemic threat, but we'll also would like to touch on base on what are the steps that the government needs to take to keep the citizens of India, especially Delhi, safe. So thank you so much, Guleria and Professor Guleria, and over to you.
Thank you very much, Dr. Ryan, for having me. And I'd like to take this opportunity to thank the Global Health Alliance for inviting me to this One Health Summit 2025 and asking me to really give a talk on these two very important subjects. As a matter of fact, I would say both of them in some ways are epidemics or pandemics in their own right. If you start looking at the current situation as far as facing the next pandemic threat is concerned, I would say that if you look at this last 25 years, this century, this has been a century of outbreaks and pandemics. We've had two pandemics in the last 25 years, the H1N1 pandemic in 2009 and the COVID-19 pandemic, which happened in 2019. We've had multiple outbreaks, SARS, MERS, Zika virus outbreak. We've had outbreaks of Nipah virus in India. Ebola has spread from Africa to other parts of the country. And there have been news of outbreaks happening in many parts of the country. And as we start looking at these outbreaks critically, it's important for us to understand that they affect every state of society. They affect livelihood, they affect human health, they affect the governance pattern that we've seen, and we saw this during the pandemic. They affect social and humanitarian needs, and the economic system, and also is thrown into a disarray. And therefore, there is a need for us to develop strategies to meet this new threat of rapidly emerging pandemics. I think the important issue is that what should we do as far as the next pandemic is concerned, or because I personally believe that we are going to have more and more pandemics in this century, and therefore there is a need for us to develop two things. One is what can we do to treat people who face this threat of the pandemic. At the same time, how do we protect healthcare services to deliver care for other illnesses? One of the silent and really not accounted for morbidity and mortality during COVID-19 pandemic was the other illnesses that suffered. People with cancers, their diagnosis got delayed and they went into advanced cancers. In children, immunization program was not there. And there was a lot of other delay in diagnosis. The tuberculosis program in many parts of the country, both in India, developing world, and in Africa, suffered because of delay in diagnosis and inadequate treatment. So that is the other thing, that how do we manage a pandemic, but at the same time make sure that health services work and they are not really threatened. And therefore, I think there is a need for us to look at various challenges that we face. First of all, I think at a global need, we need to increase awareness. We need to have surveillances in place so that we can pick up an outbreak early rather than late. And we have to have an action plan so that we really know what we can do to contain the outbreak so that it doesn't spread to other parts of the country or the other parts of the world. So an action plan, awareness, and surveillance, I think, are key. And there has to be a global system. There is only already some sort of a global alliance, but a global alliance for surveillance, which is more robust, and data sharing, so that people across the world can know what's happening in different parts and are prepared for any outbreak that may happen, depending on the type of outbreak that happens. It's also important to remember that we are seeing this outbreak because trade, connectivity, and travel has become much more. You can travel and take the infection from one part of the world to the other while you're in the incubation period. And if you're not aware of the travel history, you can cause an outbreak in that area because general precautions would not have been taken. There is also growing urbanization. We are encroaching into the environment more and more, and therefore a lot of zoonotic species, zoonotic viruses which are there in either birds or in animals, are jumping species, becoming human viruses and causing human to human spread. Therefore, there is a need to really look at technology. How can we harness technology to be able to predict the new outbreaks using artificial intelligence and various other means, and develop rapid response strategies as far as this is concerned. Also, I think there is a need to focus a lot on research. Two things that we learned during the COVID-19 pandemic was the long time it took to develop a vaccine. And therefore, there has to be now, with new platforms available, the mRNA platform and new platforms available, a lot of countries are looking at having a vaccine in less than 100 days. So, a strategy of having rapid development of a vaccine if there's an outbreak, and also looking at how can we develop good antiviral drugs for an outbreak. If you look at what happened during COVID-19, for most of the time of during the pandemic, what we used were repurposed drugs. Even remdesivir was a repurposed drug, which is actually for treatment of Ebola. So, a strategy of investing in research, both for developing broad spectrum antiviral for emerging threats and for looking at how can we upscale vaccine development for new viruses, is, I think, very, very important. And I think data sharing is also very, very important. These are key points that I would like to highlight. I think we need to do if we really want to find how we can face the next pandemic. Coming to your second part, I'll just take a few more minutes. I know I have limited time. So the second part is basically regarding what you called about the AQI, the pollution. If you look at the Health Effect Institute's data of 2024, it suggests that almost 8.1 million people globally in 2024 died because of air pollution, and most of these deaths occurred in the developing or the emerging markets. Now, if you look at it critically, this number is more than the number of people who died because of COVID-19, as per WHO data. Therefore, we are having more deaths because of air pollution, but we're not able to document it because this is a silent killer. Air pollution will lead to worsening of heart failure, worsening of an underlying COPD, or in an elderly person, it will lead to worsening of his chronic condition leading to hypoxemia, admission into the casualty or admission into the ICU, getting him on a ventilator, and then other associated infections would further deteriorate things, and this would lead to higher mortality. It's affecting the growth of children, and long-term exposure to air pollution is being now linked to strokes, dementia, Parkinson's disease, chronic heart disease. As a matter of fact, the European Heart Society suggests that living in an area with high pollution is as much a risk factor for heart disease as cigarette smoking or high cholesterol. So I think it's very important for us to develop strategies, and we need to look at strategies which are local for our own country, which are also looking at the problem that we have as far as the source is concerned, the source of or the emission of these pollutants. How can we really control that, whether it be vehicular traffic, construction, stubble burning, or various other sources of pollution? How can we really help in decreasing the pollutants coming out? How can we make cities more environmentally friendly? How can we increase awareness? And at the same time, balance that with economic growth, industrial growth, which is happening in this part of the world. So I think those are things that we need to do, and those become very, very important strategies. The government of India, of course, has strategies in place, but I think implementation is the biggest challenge. So we have a lot of plans, but I think implementing them, and implementation means that they have to be practical, they have to be something which are accepted by the public or by the user, where it's doable rather than it's being only on paper. Also, I think it's important for us to understand that the reason why we see a lot of air pollution in winter months in central India, or which is known as the Indo-Gangetic Belt, is basically because this is a landlocked area. When you have cold air and when you have very little wind velocity, there is the pollution which is emitted tends to stay at ground level because of inversion and because of low velocity. We have very a large number of days which have smog and which has pollution, and this becomes a big source of health hazards. So there is a need for us to really develop strategies not only for Delhi NCR region but for the entire central India, because if you start monitoring air quality there, it will be equally bad.
No, thank you so much, Professor Guleria, for touching on all those very, very important points. As you mentioned, especially in the non-communicable disease. We had the director for WHO, Maria Neira, yesterday speaking, and we've got the president of the European Society of Cardiology speaking in a couple of hours as well at the conference. And India has always been a very challenging country, as you know, that we are the most populated country in the world, number one. Number two, there are several other challenges. So I think, don't you think that there is a big need for a national campaign by the government, policymakers, researchers? One of the things that we really lack in India is databasing, because we don't know how many number of patients with heart disease there are, how many patients of heart failure patients there are. So I think research databasing is something that is really much required and has to be a robust system through the government. So all these, because we still speculate whether all these deaths which are happening, sudden cardiac deaths which are happening post COVID, we have been saying that on the news, on the TV channels, that it is all related to COVID-19 vaccine, COVID-19, although AIMS did publish some report recently suggesting none of these deaths in sudden cardiac death in young individuals were related to COVID-19. But we don't do, for example, cardiac biopsies in patients with sudden cardiac death. So in UK, we have at least 12 healthy young individuals dying on a weekly basis from sudden cardiac death, from cardiomyopathies, ARVCs, or electrical disturbances of the heart. And the reason we know is because we do post-mortem cardiac biopsies on all those sudden cardiac deaths. So I think there is a need for a robust data system, a robust research that is required in across all medical areas in India, especially, I think.
Yes, I do agree with you. There is a need to develop a good database. There are moves to do that, but I think two things are very important. Data which is reliable and robust, and which is on an electronic basis so that it can be shared, and data sharing should be something which is there. There was a large body of data which was available during COVID, but if it could have been put on a common platform where everyone could have really analyzed it, probably we would have been much more wiser than what we were during that point, because the data for various reasons was not shared as much as it should be. But I think that is very, very important. As far as having autopsies are concerned, or trying to do a virtual autopsy is something that is coming up. But like you rightly mentioned, there are very few centers which are doing it. For example, PGI Chandigarh regularly does post-mortem for all individuals that die in the hospital, whether it be sudden cardiac death or whether it be because of an unknown cause. Their autopsy rate for patients who die in the hospital is almost close to 80 to 90%. But that is not followed in a large number of hospitals across the country, for the simple reason that there is a little bit of stigma attached with that, and there is sometimes a lot of social pressures not to do it. But I think there is a need to increase awareness among the public, both in terms of science, in terms of the strength of data, and being able to try and develop strategies where there is a lot of public participation as far as science and research is concerned, so that there can be a sort of a combined effort in trying to decrease various issues. It could be air pollution, it could be antimicrobial resistance, it could be infection control practices, it could be picking up an outbreak early by good surveillance and observing things. So, all of that needs a lot of involvement, research, and I think awareness, which I think is something that we need to do at a big level.
No, thank you so much again, touching on all those very, very important points. And I think, as you rightly said, if you look at the global burden disease data, non-communicable disease, respiratory, heart, kidney, diabetes, cardio, renal, metabolic are going to be the main causes of death in the next 10 years. That has been projected by the WHO as well, because they did a pulse survey recently which suggests that many of the targets in non-communicable disease are likely to be missed. And again, focusing on all these NCDs, focusing on all these reasons why we are getting it, doing the right prevention at the right time is extremely important. So thank you so much, Professor Guleria, for joining us. We'll be taking your comments forward in the project report that we'll prepare from this conference, and we'll be discussing this further with UN, UNDP, WHO, and other bodies. And thank you so much for all your support that we get from time to time. And we look forward to keeping in touch and get touching base with you very soon again. Thank you so much
Thank you
again.
very much for having me. Thank you
Thank
very
you so much.
much.
Thank you.
Bye bye.
Bye bye. With that insightful discussion with Professor Randeep Guleria from India on respiratory medicine, we are now moving on to cardiology. And again, we are very privileged to have Professor Derek Connolly, who's a professor of interventional cardiology in Birmingham and Midlands Metropolitan University Hospital. He's a globally recognized leader in preventive cardiology, professor, holds a PhD from University of Cambridge, and again, he is a senior fellow for the Royal College of Physicians for the European Society of Cardiology. He is also a chief investigator for more than 30 landmark cardiovascular trials. And we are very privileged to have Professor Conley. Unfortunately, he was on call this morning, but he has very kindly recorded his video and his message. And we are very privileged to play that video on behalf of Professor Derek Conley and listen to his insightful discussion on the mega trends in cardiology.
Hi, everybody. It's Professor Derek Connolly from Birmingham. I'm going to talk about lipids over the next 10 minutes or so and hopefully bring you up to date on where we are. We all know that ischemic heart disease and stroke are the number one killers worldwide. And we know that atherosclerosis, this lifetime exposure to cholesterol, results in atherosclerosis. And we know it's the area under the curve. The higher your cholesterol, the longer it's high, the more likely you are to develop an atherosclerotic plaque. And it's not just LDL cholesterol that is a risk factor. We know it's the main risk factor when it comes to lipids, but lipoprotein A is increasingly recognized as our VLDL remnant cholesterol. And you're going to see more studies regarding this, but really it is all the apolipoprotein B containing lipoproteins that are responsible for atherosclerosis. And remember, your LDL, your total cholesterol, is a little bit variable in your life. It is very low when you're a baby. It rises during adolescence. It peaks in men, as you can see, around 50. Women, there's a jump after the menopause. But the bottom line is you have to keep measuring it, which is important. And we know that it's a risk factor. This is data from Paul Ridker in Harvard last year or so, which showed that for women, yes, inflammation is important. Yes, LDL is important, and lipoprotein A is important, and all of them multiply together to give you that cardiovascular risk. So lipoprotein A is becoming quite important, and of course this is European data showing much the same both in men and women this time, that the risks multiply together. You can see if you have all three, your risk is the highest. Now, we also know that LDL levels are physiologically too high. When you're a baby, your LDL level is 0.8 in UK money, 30 in American money. And we know most wild animals and simple hunter-gatherer humans have much lower levels of total cholesterol and LDL cholesterol than we see in normal life. We also know there is a big genetic component, and this is predetermined. We know this from big studies like the UK Biobank, 500,000 people's genetics. It determines your blood pressure, it determines your LDL cholesterol and your lipoprotein A, and therefore a lot of what we're dealing with is genetics, and people with polygenic disease are much more common than those with single gene disorders, such as with the LDL receptor. And we also know, and this is modeling from Brian Ferencz, that if we manage to lower LDL cholesterol by around 50%, we'd effectively negate heart disease. And the earlier you treat, here Brian's got it starting at age 35, the bigger the benefit. Now, of course, we don't do that. We wait till someone's had their heart attack at a much older age, then we try and lower the LDL. But if you get in early, and it may be the gene therapies coming forward from places like Verve Therapeutics will do this. If you get in early, you need much lower LDL cholesterol reduction, and you're effectively going to negate cardiovascular disease. In fact, there are lots of studies. This is a study from Colin Bagent and Jane Armitage in Oxford, effectively saying if we gave everybody in the UK lipid-lowering therapy age 40, we'd effectively negate heart disease in all of the modeling, cost-effective as well as saving lives. What's more, we know that having a low LDL is safe. This has been a declaration by the American Heart Association that LDL is a byproduct. There is no lower limit. Lowest is best, and you're not going to get any major adverse events. If you look at this study from our Fourier data, Bob Giuliano presented this, ostensibly showing no increase in hemorrhagic stroke, but a big reduction in ischemic stroke in our Fourier study when we took the median LDL down to 0.8, with people all the way down to 0.2 and no issues, but a big reduction in ischemic stroke. So aggressive LDL cholesterol reduction doesn't appear to change cognition, and if anything, it's lowering ischemic stroke, which is important. So we have lots of ways to lower LDL. We've studied these, largely starting with the statins, but now many other therapies, both in secondary and primary prevention. It is 30 years this week since the presentation of the West of Scotland Coronary Prevention Study. We now have the 20-year data published. All it does is reduce cardiovascular disease, no increase in cancer with the weak statin, pravastatin. But of course, secondary prevention patients are of much higher risk. Bang for your buck, absolute relative risk reduction, absolute risk reductions much greater. And we know this from studies like the TNT study 20 years ago. Give everybody 10 milligrams of atorvastatin. If they tolerate that, give them 10 or 80 milligrams. And you can see here over 5 years a big reduction in cardiovascular events on those on the higher doses of atorvastatin. So we also know this is all about LDL cholesterol exposure. You know, the UK Biobank has 50 years of exposure time. So we know the higher your LDL area under the curve, the more likely you are to develop cardiovascular disease. We have the UK Biobank and other biobanks. We have prospective cohort studies. We also have all of the randomized controlled trials. And ostensibly with randomized controlled trials, if you work at how low the LDL goes and using the cholesterol treatment trial as collaborative equation, you can work out the benefit you're going to see. And pretty much all of the studies line up for that. Now, what statins do we recommend? These days, they're all generic and off patent. Atorvastatin and rosuvastatin are the ones we should use. I take 40 milligrams of atorvastatin. I get exactly a 49% reduction in my LDL cholesterol, which is very good indeed. Now, as we have changed the concept of lowering LDL, when we put someone on a statin, we kind of went for a target of, in American money, 100, 2.6 in UK money. But as we've been able to lower it further, we've changed our goalposts in the European Society for people with heart disease from 2.6 to 1.8 and now 1.4. And as we've done that, we've realized that with statin only as a monotherapy, the majority of patients don't achieve it. Only a third reach 1.8. Here you can see in this study, and only about 1 in 10 reach 1.4. We also have the problem that statins are not taken by patients. Perceived or real statin intolerance is absolutely something we all see every day. And in fact, as you can see in this study, in 4.1 million people in statin trials, close to 10% of the patients are going to end up not taking them. In practice, it may be much more than that. So we do need to have multiple therapies to take. If someone has amlodipine for blood pressure and they get ankle swelling, you don't just stop the amlodipine, you start them on something else. The good news is we have lots of other therapies to lower cholesterol. And of course, it doesn't help us that the media don't like things like lipid-lowering therapies. Here in the UK, they said that there was a potential killer complication with statins. It turned out that 10 people over 30 years with statins had had myasthenia gravis, which might be associated with statin therapy, but nobody died and only 10 patients. Remember how many million patients are on this. But that week, we reckon over 1 million patients stopped their statins. So it's really important from a public health perspective that we get things right, because certainly if you don't take your statin, and the Swedes have shown this in Sweetheart, these are patients with bypass surgery, you're twice as likely to die, as you can see. Beta blockers had no major effects. ACE inhibitors, angiotensin receptor blockers, blood thinning agents did have an effect. The biggest effect of all was in lipid lowering therapy. And we've concentrated a lot in statin therapy, but more recently, we're now concentrating on all other therapies. Now, the first therapy, of course, is ezetimibe. It's virtually side effect free. It's incredibly cheap and off patent, but it'll only lower your cholesterol in addition to a statin by about another 20%. We do have study evidence. The Improve It trial quite clearly showed a reduction in events that we would anticipate from all of the equations. And that is quite a big benefit when you put it into higher risk patients. But of course, the logical thing is to give it with a statin or other drugs as an add-on therapy, ideally in the same tablet, and then you're getting an extra bang for your buck. And of course, what we've shown with all of this is that lowering LDL cholesterol works, as you can see. This was the most recent bar one of the European guidance, and we introduced this target now of 1.4 for anyone with proven atherosclerosis or high-risk features. Now, the only way you're going to achieve this, and we published this in European Heart Journal in 2021, is by combinations of therapy. Think of it like blood pressure, where we use combinations of therapy, like diabetes, like heart failure. Combinations of therapy achieve the levels we know work. And we've now got evidence from Sweetheart that this is the right thing to do. If you get the cholesterol down much further and early post ACS, you reduce MACE rates. And it's important that we get therapies that the patient will keep taking. So what about the LDL receptor? We've mentioned them. Of course, this is the folly, the problem in familial hyperlipidemia. But there was a small percentage of patients with familial hyperlipidemia that had normal LDL receptors. They turned out to have a high level of a protein called PCSK9. PCSK9 binds to the LDL receptor, so that when the liver internalizes the LDL receptor attached to the LDL, it doesn't just get rid of the LDL, it gets rid of the receptor as well. So having a high PCSK9 meant that you had much, much higher LDL. And there were people in the world with no PCSK9 and they seemed to be normal. So it was an ideal target for therapy. And of course, we did this with the Fourier trial, where we gave an antibody against PCSK9, which lowered LDL cholesterol by another 50% or so. And we showed in 3-point MACE another 20% reduction in cardiovascular events on top of statin therapy. And of course, the benefits in year 1 were good. The benefits in year 2 and 3 were even bigger, suggesting it takes time to stabilize the plaques. It takes time to get the cholesterol out of the arteries. And of course, you're not therefore dealing with the first event. You're dealing with all events, total events. And in this study, we showed firstly that the median LDL here you can see was 0.8 on therapy, people right down to 0.2 with no major adverse events. But not only was it the first event that was reduced, with time, the second event was even more reduced, the third even more reduced, the fourth even more reduced, of course, as the plaques were stabilizing. And there was no bottom to LDL cholesterol. So I'm not worried about a low LDL cholesterol. And certainly it doesn't cause problems with cognition. I was UKCI for this study, the Ebbinghaus study, probably the most negative study the New England Journal has ever produced. And of course, we know the more disease you've got, we showed this in Fourier, the more benefit you get from a super low LDL cholesterol. So you can see here, 4S, the first study with statins, lowering your cholesterol on one side, Fourier taking it down to a very low level with no adverse events, just a reduction in cardiovascular events. Are there any more therapies? 4 years ago, I introduced bempedoic acid. In the UK, it's an alternative cholesterol synthesis inhibitor. It works at a different point from statin therapy, but it's NICE recommended. We have getting on for about 100,000 patients on this in the UK. It works 2 enzyme steps above HMG-CoA reductase, the target for simvastatin and other statins. And because it's only in the liver and it's a prodrug, you don't see the muscle side effects. Of course, we have got data for this. The clear outcomes data was published in the New England Journal and showed a big reduction in cardiovascular events, as you can see. So certainly as an alternative to statin therapy, and those that can't take statin therapy, this is ideal. Importantly, when we look at the data for it, you can see it points in all the directions. It follows exactly what we would expect from the cholesterol treatment trial as collaborative. And if we look at the overall data in primary prevention, about 30% were primary prevention, there was a reduction in total mortality. You can see there that at the bottom of 27%. So someone can't take a statin, I'm not going to put them on anything, has gone now. You should put them on bempedoic acid. Ideally with ezetimibe, you're getting about a 38% reduction in LDL. And of course, we predict the event rate from the cholesterol treatment trial as collaborative, and you can see clear outcomes was exactly where we anticipated. So we've now put this in international guidance, in the European guidance all around the world, and it's now definitely a choice. What about small interfering RNAs? Lots of them are coming. The first one is inclisiran. Of course, this was the discovery that won the Nobel Prize for Chris Mello and Andy Farr a few years ago. But ostensibly in the UK, we've been early adopters of this. We have about 60,000 patients on it. We think about 1 million doses of this have been given worldwide. And because it lowers your LDL by another 50%, it blocks PCSK9 in the same way as evolocumab, but this time by stopping its synthesis, you get most of your patients to target. Early studies suggest a reduction in cardiovascular events, roughly where we would expect. There are two big ongoing trials which will present in the next couple of years, ORION-4 and V2P. I've written an article all about it, but it's now over 1 million doses worldwide, it's here to say. One thing to say, though, is we studied the Santorini study, a European study of all the big units around Europe, and we showed remarkably in high-risk patients and very high-risk patients, over 20% were on no lipid-lowering therapy, and the vast majority of patients were not reaching target. Initially, we were seeing only about 1 in 5 reaching target. Unfortunately, the UK was one of the worst offenders for monotherapy, not using combinations of therapy. Exactly the same data, by the way, has been shown, as you can see here in America, and the key is combination therapies. This is a graph by Professor Banak from Poland that has now been included in the European Society guidance. The idea is to use combinations of therapies. In the UK, and this is the NHS in England lipid guidance, we have that as mandated. What else is new? Well, homozygous FH has a few new therapies. One of them to mention is an ANGPTL3 inhibitor. ANGPTL3 is an enzyme that blocks lipoprotein lipase in the blood. If you stop that working, the ANGPTL3, you get higher lipoprotein lipase. You get about a 38% reduction in LDL in patients that have abnormal LDL receptors, which is quite important. The other thing to mention is obicetrapib is coming. This is a CETP inhibitor. My friend John Castelline in Amsterdam has been pushing this, is getting through its studies. We have increasing studies. The PREVAIL outcome study comes next year. But ostensibly, this lowers your LDL cholesterol by another 30 to 40%. It doubles your HDL, it lowers your lipoprotein A, and it seems like it works completely differently to the others, and we'll be able to use this in combination. Really interesting data coming out for this, suggesting benefit potentially for vascular dementia as well, and it seems to be safe. And as you can see from the right here, it's not just lowering LDL, but it is doing lots of other things that we might think is advantageous. So watch about it, but particularly watch out because we think it may be something we could use potentially in Alzheimer's disease. So, like in the cinema, what's coming? The coming is more PCSK9 inhibitors, more small interfering RNAs in a variety of reasons. And the bottom line is that we're going to find other ways to treat these therapies. I'm doing a trial with AstraZeneca called Azure at the moment, which is with an oral PCSK9 inhibitor. There's a couple of others in development as well. They'll be useful. One of them is with Merck for a therapy that's going through the CORAL program. That's going to be very, very interesting. And they've got data suggesting that it's working as well. But there are other drugs around too. This is a drug originally developed particularly in South Africa that seems to be a monthly injection that works. But the bottom line is that we now have lots of therapies. We know that atherosclerosis is on the rise worldwide. We know LDL is one of the major risk factors. We can lower LDL, which is really important. And when we reduce it, it lowers outcomes. And the key thing, though, is we're going to have to use combinations of therapy because that's the only way we'll achieve the levels that we know work. Remember, LDL, you have to measure several times. Lipoprotein A at least once in your life, but LDL, please keep measuring it. Very low LDL works. If you're getting into problems, ask a lipid specialist, but the truth is most people can manage most patients. And the bottom line is lower for longer is better. And I think at that point, I'm going to stop. Thank you very much for listening. And any problems at all, go on to Twitter and I'll quite happily answer any questions.
Thank you so much, Professor Conley, for that inciting talk on lipid management and obviously the journey ahead, because we are going to see lots and lots of new drugs coming, as Professor Conley mentioned, in the lipid space. But as I said, that it is extremely important to address those lipid challenges, do all the right things, especially in secondary prevention, make sure that all those LDL triglycerides are addressed properly, because there are lots of treatment options. Statins and fibrates are not the only one. There's PCSK9, inclisiran, obicetrapib, CTP inhibitors coming through, small iRNAs coming through. So lots and lots of new drugs coming through. So very exciting journey ahead for lipid management. So on that note, I'm happy to introduce our next speaker, who again needs no introduction in the field of cardiology, especially interventional cardiology. Professor James Nolan is a professor of interventional cardiology at Keele University. He has been an interventional cardiologist at University Hospital of North Midlands for several decades now. He's a globally recognized pioneer in transradial coronary intervention. Professor Nolan initially trained in London, Leeds, Edinburgh, and Amsterdam. He's also been a recipient of British Cardiovascular Society, Interventional Society's Tony Gershlick Lifetime Achievement Award. He's delivered several keynote talks at EuroPCR masterclasses. He has led lots of initiatives, not only in the UK, Europe, but globally. We are very privileged to have Professor Jim Nolan today addressing on radiation exposure for HCPs and its impact on health. As I said, that Professor Nolan does not need any introduction, because he has trained several hundred cardiologists who are practicing in the UK, Europe, and globally. So we're very privileged, and thank you so much, Professor Nolan, for joining us this afternoon. So you should be able to share your screen, Prof. And if you can open your camera as well if you want to. We can see your screen coming up. You're on mute, Prof. So if you can unmute yourself, then we could hear you as well. Thank you, Prof. We can see you and we can hear you.
Okay, fantastic. Thank you for your kind words there, Rajay. So I'm going to talk about radiation exposure and its implications for healthcare professionals. So this is the very first X-ray that was ever taken. This is Mrs. Rontigen's hand. This X-ray dates from 1895, and Mrs. Rontigen's husband discovered X-rays by accident when he was working with cathode ray tubes, and found that photographic films in a cupboard were being fogged, and he realized that the tubes were emitting some unknown rays. And this is how the old guys used to work at the beginning of the radiological era. The X-rays were produced in this big wooden box, and they commonly used their hands to modulate the output of the device. They put their hands in to the X-ray beam. If they couldn't see enough of the bones, they turned the intensity of the X-rays up. Now, that's not really a good idea. These are the hands of one of the early X-ray pioneers. You can see, if you look at the dates at the top, that he didn't have a long life. And before he died from a radiation-induced cancer, he lost digits and limbs. And most of these early radiation pioneers died as a result of the X-rays they were exposed to. And quickly people became aware of these detrimental effects. And just as a guide, if you receive a dose of 100 millisieverts, you will have an increased cancer risk. If you receive a dose of 500 millisieverts, you're quite likely to get acute symptoms, feel unwell, have detectable changes in your blood count. And if you receive 2000 millisieverts or more, you will be severely ill, and it's quite likely that you will have a fatal outcome. And these doses in the 2000 to 10,000 millisievert range were what was received by the firefighters on the roof of the Chernobyl plant. 100 to 500 is much more like the doses that were received in the Fukushima accident. So remember those levels. 100 millisieverts increases your cancer risk. Now, with the increasing awareness, catheter labs and X-ray equipment was improved. This is a catheter lab from the 1950s. You can see that the operators are wearing some lead shields, lead aprons, the type of things we would wear nowadays. But there's very limited additional shielding. But nonetheless, this type of equipment was enough to open the era of interventional cardiology. This is a chest X-ray of Werner Forssmann. This is the first ever cardiac catheterization performed in a human. And Dr. Forssmann actually performed this on himself, put a catheter up his arm and into his right atrium, and then walked down the hospital corridor and had this chest X-ray taken. This is the first ever coronary angiogram, which dates from 1958, done by Mason Soanes. And this was actually done by accident, but the patient survived, and the doctors, Dr. Soanes and his colleagues, realized that this was a sign that you could perform invasive coronary angiography. Now, this is the type of catheter lab that we live and work in now. It's highly computerized. There's lots of shielding. The dose of X-rays emitted is much less than it was in those old systems, but nonetheless, it still represents an issue. You can see the difference in the quality of the image here for a coronary angiogram compared to Soanes's first angiogram. But when you look at the X-ray outputs, in association with cardiac catheterization, you see a little bit of an alarming pattern here. So a chest X-ray is 0.02 millisieverts exposure, 2.5 days worth of extra background radiation, but a complex angioplasty is 25, sometimes 50 millisieverts per case, which is an extra 10 to 20 years of background radiation. So the cardiac cath lab is a very radiation intense environment. And the radiation is not just a risk for the patient. So the primary beam of the X-rays passes through the patient, the yellow beam here, but the patient's own body, their own cells, scatter the X-rays out. And it is scatter radiation that represents a danger to the healthcare workers. And of course, in Western societies, we have a very big problem with an increase in BMI. This is a patient of mine. You can see here that radiation exposure for the patient in the top panel and the operator in the bottom panel increases dramatically as the patient's BMI increases. And as we deal with more and more patients who have elevated BMIs, radiation exposure in the cath lab is further increased. As patient exposure is increased, there's a direct linear relationship. So you as the operator or the healthcare worker in the cath lab gets more as the patient gets more. This radiation exposure can be associated with a major impact on the health of your patients and also of the staff, even in contemporary practice. The first thing to be aware of is direct tissue injury. And this is a patient who had a diagnostic coronary angiogram and then a PCI. The operator omitted to move the tube around enough to vary the views, and this patient had a very severe skin injury, and these often require very prolonged treatment and skin grafting. This was a patient who had an EP procedure, and unfortunately, their arm was left down by their side, very close to the X-ray tube, resulting in this very severe, damaging skin injury for the patient. Now, we saw earlier on that the early X-ray pioneers used to put their hands into the main X-ray beam, but I see contemporary operators doing it. You can see here the operator's hands in the beam here. He's having some difficulty with a radial procedure, and he's put his hand into the primary beam, and I often see that in different places around the world. Also, you see it with people doing TAVIs on occasions. Putting your hands into the primary X-ray beam is a really bad idea. These are the hands of a consultant in contemporary practice. This is from 2018, who regularly put his hands into the primary X-ray beam. And these injuries resulted in amputations and loss of occupation. So the kind of severe damage that we saw early on can still happen. These are the legs of an interventional cardiologist in the UK, and in this report, they report loss of hair on their legs. If you look on the left-hand side of the slide, you can see that the operator here has lost quite a lot of hair on their legs. And this is because X-ray exposure under the table is a very intensive zone. And underneath that hair loss, of course, is bone marrow, rapidly turning over cells with malignant potential. This is a posterior capsular cataract. You can see lots of fogging of the eye. This is a specific radiation-induced cataract injury. And this data is from a study where people attending a cardiology conference were asked to volunteer to have slit lamp examinations in their eyes. And you can see that posterior capsular lens opacities were present in only 9% of the controls, but in 45% of the cath lab nurses and 52% of the cardiologists. And I have personal knowledge of people, cardiologists in their 40s, who've had lens implants and cataract extractions. And I think because people have not been aware enough of this and not taken enough care of their eyes, I think we'll see an epidemic of cataract formation in interventional cardiologists. Now, an even bigger worry is perhaps cancer induction. These two studies look at markers of DNA damage in people who work in the cath lab and are exposed to medical radiation. So if you look on the left, the grey bar is non-exposed individuals, and then we have low exposure workers and high exposure workers. And you see an increase in DNA damage proportionate to exposure. And on the right here, there is a direct linear relationship between exposure dose and measured DNA damage. And it's not surprising when you see that working in the cath lab damages your DNA that it results in a linear increase in the risk of developing lifetime cancer. It's certainly a worrying finding. Now, one part of the body that's very difficult to protect in the cath lab is the operator's head. And if you look here, the top panel is patient's exposure and the bottom panel is doctor's exposure. Interventional neuroradiology doing complex intracerebral procedures will often result in a brain organ dose of 200 to 1000 millisieverts for the patient. But the lifetime exposure of a catheter lab worker can be 2000 millisieverts. It's hard to protect your head and your brain receives a big dose. And this can be the result, a brain cancer. And here in this 90,000 patient study, brain cancer mortality was more than doubled in patients working with medical radiation. A really worrying finding. This data looks at neuromodulation proteins, the things that keep your neurons working properly. And the grey panel is controls and the darker panel are interventional cardiologists. And in all the studies, neuroregulatory proteins were down-regulated in people exposed to radiation as a result of their job. And if you lose the ability to regulate how your neurons are functioning, the end result is an increased risk of dementia here, a statistically significant increased risk of dementia, and an increased risk of Parkinson's disease and other neurodegenerative disease. A real worry for people who work in a cath lab for a long time. Another factor that we should be aware of is that the exposure to 100 millisieverts has a differential effect depending on whether you're male or female and young or old. Now, most of our patients are in that 70 to 80, 60 to 70, 80 age group, and their risk of developing a fatal cancer is relatively low. But if you expose people at a young age, in the first 10 to 20 years of their life, their risks are much higher, as you can see from the bottom line. And you can also see the blue line is males and the red line is females. And females appear to be more susceptible to the adverse effects of radiation. So here, this is a study of over 3 million children exposed to radiation. And the lines represent their lifetime risk of radiation-induced cancer. And the top line there is really a very much enhanced risk of cancer. So you can see that age exposure is important. And here is the risk of breast cancer in women exposed to occupational radiation, and it's almost doubled. It's a real worry. As a result of that, in the most recent BSIS update of recommendations for radiation protection, we recommend that women have some specific additional auxiliary protection. Low-dose radiation exposure also damages vascular endothelium, and it can start a cascade of processes that enhance the development of coronary atheroma. And you can see here that as the dose of radiation rises along the horizontal axis, your risk of ischemic heart disease is significantly increased. So we have a risk of skin injuries, eye injuries, a risk of cancer induction, and an increased risk of vascular disease and ischemic heart disease. Now, you can reduce your radiation exposure. This is, sorry, I don't know what that. This is an early radiation worker. Now, nobody's going to work in the cath lab or in an interventional radiology lab dressed like that anymore. However, shielding is really important. This is dosimetry around the cath lab, color-coded for readings. And you can see that the above table shield puts the operator into a much reduced radiation zone, indicating that you can control your radiation exposure. And now we have many different types of radiation protection systems. On the left is the egg nest. Next to it is the Rampart system. Then we have the zero gravity system and other ways of controlling scatter radiation. And all of these systems work. Without them, the control red bar is much higher than the levels recorded with the Rampart, the RadPad, Drapes, and the STAR system. Is that beneficial? If you look first at the two red bars, these are markers of DNA damage pre and post going into the cardiac cath lab. If you then put leg shields on, extra shielding, you can see that rise in DNA damage is eliminated. So extra shielding is important. Now, unfortunately, not everyone is good at radiation protection. So you can see here, if you compare dose area product, dose delivered to the patient in England as opposed to Greece or Finland, you can see that it's much higher for the same procedures, for cardiac procedures in some countries than it is in others. And the same pattern is present for individual operators. So these are 9 or 10 operators, all performing the same procedures by the radial or the femoral route. And at the top here, this operator is very good at radiation protection. And this operator at the bottom here is not very good at radiation protection. And he delivers 8 times the amount of radiation as the top operator for the same procedure. And, you see these kind of differences from poor radiation protection practice. This is the use of common, easily available radiation protection practices in a survey. And the green bar represents people using it as a routine. And you want to see the green bar as far to the right as possible. In only 2 of these 9 standard protocol options that we have available, do you see that the operators are regularly using things like timely termination of cine recording and keeping the image intensifier close to the patient's chest? All the other things are imperfectly applied. So, my message to all of you would be that radiation protection in the cardiac cath lab is important. You can find more information in this heart publication from 2020, which covers the ways you can improve your practice. And you need to remember what you're actually exposed to when you go into an environment like the cardiac cath lab or an interventional radiology lab. The annual exposure for interventional cardiologists is around 5 millisieverts, which is equivalent to 250 chest x-rays or 2 years of additional background radiation. And in a lifetime at that level, you will receive 200 millisieverts, i.e. twice the cancer induction level. That's equivalent to 10,000 chest x-rays or 80 years of additional background radiation. And remember that you're allowed up to 20 millisieverts. And if you receive 20 millisieverts a year for your working career, you'll have something like 40,000 chest x-rays worth of additional radiation. Just to finish off, I'll show you my own personal radiation monitoring data. My average exposure per year was 0.372 millisieverts. And so over a 40-year career, I would accumulate something like 15 millisieverts. And you can get that much additional radiation if you move from the north of England, where it's grey and cloudy all the time, down to the southern France, where it's beautiful and sunny and you get more cosmic rays. So I was good at radiation protection because I was worried about it and I was careful about it and I educated myself about it. So in conclusion, radiation exposure for healthcare professionals is a significant health risk. It's associated with increased rates of cancer, cataract formation, skin injury, neurodegeneration, and cardiovascular disease. They are your risks when you go into your radiology department or your cardiac catheter lab. Those risks are quantifiable and they're increased. Optimized protection strategies can be used to minimize the exposure, but you have to educate yourself about those protection strategies. Knowledge and application of protection strategies is patchy and limited. If you're good at radiation protection, you can work in a cath lab or an interventional radiology department without major exposure and its attendant risks. Thank you.
Thank you so much, Prof. That was very, very insightful, very knowledgeable. In fact, I have also learned a bit more today. But when people join the cath lab as a junior cardiologist, as a junior physiologist, they don't take radiation safely. I mean, seriously. There are courses in the NHS and the courses that we go to protect ourselves. But are there any more exciting way of learning to encourage junior cardiologists, junior people who are entering the cath lab, especially to learn about all these risks at an earlier stages? Are there any good courses in the UK that we can refer to?
Well, look, Roger, you make some really good points there, and I think people tend to go into the cath lab and they treat it like a video game. They press a button and a picture magically appears, but they've forgotten that next to them is a toxic entity emitting those rays. And that the problem with the way we are educated about it is that it's often delivered by physicists and people like that. And they talk to you with huge equations and complex graphs, all this kind of stuff. It's not very easy to understand what's going on. That's why I use the pictures in these kind of talks, because they are shocking pictures. That brain cancer, it happens to people.
Yes.
Those skin injuries, the cataracts. I know all people in my working life. I know people who've had all of these things. The pictures are important. So I think there needs to be a remodeled course that uses accessible information and gets the concepts over to you. I mean, I can do a talk about how to optimize your protection in the cath lab and get your levels down to the type of level I was at. Because, again, it's about the way you present the information. There's also a virtual reality program now that has been shown to have better effects on on workers' retention of information. So I think there aren't any good courses in the UK. It's usually delivered by trusts. It's usually poor quality, and it leaves people
Disinterested, because again, I did the course as well as a junior cardiologist, and as you rightly said, it was delivered by physicists with lots of complex numbers, data, and you don't take real interest unless you see real pictures like what you showed on your presentation. Because unless you see something like this, you will not be serious about it.
Yeah, absolutely. And I think we see that a lot that women are affected by these things. Women's willingness to train as interventional cardiologists is much lower than males, and a big worry for women is their radiation exposure, both throughout their career, but also during pregnancy. Now, they are things that can be managed, but the delivery of education is, in my opinion, really poor.
Yeah, yeah. No, thank you so much, Prof. We'll definitely come back to you to take some important messages on the final report that we prepared for the conference. And obviously, we'll be sending these to the British Cardiovascular Society and the ESC. So thank you so much. We're really grateful for taking time to join the conference. And we look forward to keeping in touch. Thank you so much for your time.
Thank you, Roger.
Thank you so much.
Cheers.
So, from one guru of cardiology to another guru of cardiology, I'm very privileged to introduce Professor Thomas Lushkar, President of the European Society of Cardiology. He's the Director of Education, Research and Development at the Royal Brompton and Harefield Hospital, and also Professor of Cardiology at King's College London. He's a globally renowned interventional cardiologist, and he has done lots of work in endothelial biology, pioneer in many of those important papers that have come out, especially in the European Heart Journal. He's also past chairman of the University Hospital Zurich. He has chaired several of the ESC working groups, And again, we are very privileged to listen to him as to what role European Society of Cardiology is playing in reducing the CVD burden globally. Because we know, if you look at the global burden disease data, majority of deaths in the next 20 years will still be related to heart disease. So, Professor Vishka, thank you so much for joining us today, and we look forward to hearing you.
Well, thank you very much. Do you hear me?
We can hear you. You can share your slides now.
Okay. Do you see that?
Yeah, we can see your slide.
Okay. So thank you very much. I'll be delighted to talk about the role of the European Society in reducing cardiovascular burden globally. Our mission is, of course, exactly that, to reduce the burden of cardiovascular disease. And we have developed a number of strategies. First of all, welcoming society. We take members from all over the world. We have many nations, as you know. We want, of course, to have a good membership offer. We want to provide high quality data, be it in our journals, on our registries. And of course, we will provide knowledge through our educational programs. And we're about to foster personalized medicine. And not last but not least, we want to also improve environment. We select events in centers specifically as to whether they heat or cool with non-fuel energy, among other aspects. We have currently 58 national cardiac society and 47 affiliated cardiac societies, so we're really a global society. And we have also now a office in Beijing in China, because we have increasingly attendance from there. We had a fantastic congress in Madrid with 33,000 plus attendees, excellent program, 10 hotlines with papers in the New England Lancet, JAMA, and European Heart Journal. And here is the topic is, of course, global health, and it was the 75th birthday of the society. And we work together with the World Heart Federation to stress the global health motive here. We had, as I said, 33,000 plus participants. We had people from 163 countries. We had, as a new thing, because it was in Madrid, 2,820 participants from South America. We had 1,600 from the US and 638 from China, among many other countries. And of course, to address the educational offer, we not only have the main Congress, we have congresses from the associations. We have 7 associations on imaging, on prevention, on heart failure, and acute cardiac care, on ERA, the rhythm disorders, on PCI, and for the nurses and healthcare professionals. And for that, each of them has a congress. ERA had one in Vienna, then acute cardiovascular care in Florence, prevention in Milan, heart failure in Belgrade, ACNAP, and CVI will have it in Vienna later this year. And of course, we have our guidelines that reach globally as well. The ESC clinical practice guidelines are downloaded over 8.5 million times per year. They're hugely cited 10,000 times in the medical literature. Here in 2025, we had valvular heart disease, we had dyslipidemia, we had a chronic coronary syndromes later that in 2024, and in 2023, we had acute coronary syndromes. And that, of course, fosters the heart team, because we involve surgeons for valvular and chronic coronary disease, among others. Then, of course, we also want to make sure that what we provide is really solid, rock solid. And here we published last year the revision of the level of evidence grading system for ESC clinical practice guideline recommendations. For instance, we now recommend p-values of 0.05 rather than 0.5, because obviously with p equals 0.5, the probability to be at false positive is actually quite high. And then we foster, of course, artificial intelligence and machine learning. And for that, we produce the ESC chat, your guideline companion, where you can type in questions and you get an answer right away in your clinic. You don't have to read 20 documents, each of them more than 100 pages long. So that's really important, that the access to our guidelines is easy so that it's actually used. And for further fostering artificial intelligence, we will organize end of this month the Digital and AI Summit of the European Society of Cardiology in Berlin on November 20 and 21. And of course, all together, we want to do research and foster it. Then we'll produce guidelines with a huge guideline committee, more than 100 reviewers. Then the educational activities will be based on research and guidelines. We have then, of course, the co-pilot, the ESC chat that I showed you. We also have then observations of clinical practice with our registries, EuroHeart and GRASP. We have quality standards to assure that what we produce is good. And then, of course, we can, in the registries, again, feed that into research and the next guidelines. Okay, so that is really what artificial intelligence and machine learning can provide. We can integrate the clinical information, biomarkers, CT scans, or any other imaging gadgets that the patient wears, genetics more and more, and we can derive a digital twin of the patient that allows us to really move to what, and of course we need the EuroHeart large data sets to approve this. This is what we're doing, and that eventually will lead to personalized medicine that makes us faster, more consistent, more integrative, and more precise. And of course, we have to make sure that the algorithms we're using are quality. They have a very good quality. And so they need to have to fulfill 5 critical quality criteria: clear intended use, rigorous validation, adequate sample size, openness of data and software, reporting, and reproducibility. And we discuss this, of course, continuously with the European Medical Agency, as well as notified bodies that in the EU are responsible to approve algorithms, because algorithms are considered a device. And then, of course, we have, of course, then a co-pilot that makes us faster, more precise, and safer. And of course, we need good evidence for everything, and that's the journal family that currently has actually 18 journals. We have some new ones. The main one, of course, is the European Heart Journal, and for research, cardiovascular research. But we have now journals for heart failure, for quality care, for prevention, for pharmacotherapy, for imaging, you name it. You can get all the information you need through our family. And of course, lastly, we need to actually also advocate for the heart. We do this at the level of the European Union, maybe in the future also for the World Heart Federation. But at the European Union, we now particularly lobby for a health plan on cardiovascular disease. And we want close contact to Brussels, not the national cardiac societies and the affiliated cardiac societies. And for that, we have now a Brussels office that has an increasing importance and has our policy team with a director of policy that's very experienced in getting to the European Union decision makers. And fortunately, a year ago on December 3rd, the EU cardiovascular, the councillors have announced the cardiovascular health plan, and that really hopes that with Oliver Verhully that you see here, who is the Commissioner of Health, we can move forward. But we have also talked to all kinds of other commissioners on climate, on health, on research, to make sure that we have the necessary impact to get the funding and the budget to foster cardiovascular research in the future. We have decided on 3 major topics: embracing the power of AI, restoring the EU as a world leader in cardiovascular research, and improving population health for a more resilient society. So when we look at AI, here, of course, we would like to expand the creation of disease registries. EuroHeart is not in all 27 countries yet, and many other projects that are listed here. And here is one we have. EuroHeart now currently looks at acute coronary syndromes, TAVI, atrial fibrillation, and heart failure. So the path to quality control and investigator-initiated trials nested on these registries is the vision of the ESC. And of course, we have also the Atlas that provides us with standardized data. And you can see that the cardiovascular disease from west to east is uneven. It is from the rich to the poor uneven, from males to females, and of course, from whites to colored. And we are really working on that to foster more equality in health care access and quality. And then, of course, we want to restore the EU as a world leader in cardiovascular research. And we build on a fantastic tradition. You can see that we had actually William Harvey that even created the cardiovascular system. Then René Laennec brought us the stethoscope, the symbol of the physician. Then seeing the heart with Röntgen, we just heard it in the previous talk. Then sensing the heart with the ECG, William Einthoven from Leiden. Then measuring the heart with blood pressure from Torino, from Rivarocci. Then, of course, interrogating the heart with Werner Forsman, who did the first catheterization, first pacemaker at Karolinska by Jakob Senning, treating the heart with Andreas Grünzig in Zurich, then stabilizing the heart in Lausanne with Ulrich Sigwart, then ablating atrial fibrillation with Michel Asseguer in the south of France, and replacing the pulmonary valve in London with Philippe Bonhoeffer, and lastly in Rouen, replacing the aortic valve with Alain Cribier. So we have the history, and we hope that with a health plan we can build on this tradition. And then, of course, we want to also improve population health for more resilient societies. We will get a policy in place, what a cardiovascular, cardiometabolic checkup should entail. And we foster also through a EU grant called Cities at Heart, the actual check of cardiovascular health throughout the population. So I could say that really the ESC is global. It educates physicians, it involves patients. We have a patient group, we have patients in the guidelines, we have patients in the committees of our congresses. It fosters cardiovascular research, creates cardiovascular medicine of tomorrow, and reduces, hopefully, the cardiovascular burden. And for that, I thank you for your attention.
Thank you so much, Prof, for telling us so much about the work being done behind the European Society of Cardiology. Obviously, we know that this is the biggest platform globally to really make an impact, and it is already making an impact. But if you look at the global burden disease data, heart disease, cardiovascular disease is still going to be the biggest killer. If you look at some of the reports from the WHO, which is called the Pulse Survey, many of the targets in non-communicable disease like heart disease especially are likely to miss their targets in the next 5 to 10 years. So apart from what we are doing at the European Society of Cardiology, do you think that there is a need, especially in developing countries like Indian or Indian subcontinent, where there is a tsunami of heart disease, diabetes, especially that leads to more heart disease, that we need to spend more, the government needs to spend more of their GDP on health and heart disease prevention rather than spending in war in Russia and Ukraine and Israel?
Yes, absolutely. I could agree completely. There are 3 major drivers of cardiovascular disease that we're still not controlling. The one is, of course, environment. If you live in Delhi, of course, rather than in a rural area, you're much more exposed to pollution, to noise, and we all are exposed to plastic. This is terrible. And in Geneva, they couldn't reach a decision because plastic is now in our body. If you eat fish, you actually eat also plastic, and that causes inflammation, has been shown to foster cardiovascular disease. The second problem is, of course, the pandemic of obesity or gain in weight in general. Every population gains weight currently, and this fosters, of course, diabetes, high blood pressure, dyslipidemia, renal dysfunction, insulin resistance, changes the microbiome in an unfavorable fashion and causes inflammation in the body. And this is, of course, a very, very important topic that we have to address already in children, in schools, to educate people about proper eating, avoiding soft drinks with lots of sugar and the like, but also in those who are already obese to use the novel drugs we have at hand. And the third problem, particularly in the West, but now more and more also probably in India, is the aging society. Because as you know, all cardiac diseases are very much age dependent. The older you get, the higher your risk of getting any form of cardiac disease, be it heart failure, myocardial infarction, stroke, or cardiovascular death. And therefore, we have to also approach early prevention to delay the aging process. And of course, there's a lot of research to actually study what aging processes could become a therapeutic target in the future. It's a big topic in research. So I think these are the major three pillars that we should really focus on. And of course, in development countries, as you say, the access to care is not very good. I have a fellow that works in India and runs this heart center somewhere in the south of Delhi. And he told me that people have to pay their own stent. That's really terrible, that poor people then don't get the proper quality. So access to care, good quality care is very important, not just in India, but in many developing countries. Even in Africa, if I was lecturing in Nairobi, you can get everything, but if you're a bit outside, then you get very, very bad care. And that is certainly a major problem for global health around the world.
No, that's very, very useful and important information, Prof. And we are really grateful that you took out time to speak to us. We will be taking all the key messages from all key opinion leaders in global health in the last 2 days who are speaking at this meeting, and we'll be taking it to the WHO, UN, UNDP, and all the important foundation and governments around the world so that this can be re-emphasized. So thank you so much, Prof, and we look forward to keeping in touch.
Very good. Thank you.
Thank you. Thanks. With that insightful information and the work that is being done by European Society of Cardiology, I'm very pleased to introduce Andy Dunhill from AliveCore. AliveCore, as you know, has been a game changer in the world of cardiology because they started the CardiaMobile, the cardiac device that detects atrial fibrillation, normal rhythms on your ECG. It's a handheld device which is easily available. So I hope Andy is here, Andy Dunhill, who's our global rhythm manager for UK. So Andy, can you hear me?
I can, yes. Thank you very much.
Over to you, Andy. I'm sorry we are running slightly late, so if you can keep up to time, that will be great.
No problem at all. Let me bring up the appropriate screen. Fantastic. So hopefully everybody can see my screen there. So just to introduce myself, my name's Andy Dunhill and I'm the National Account Manager for UK and Ireland for AliveCore. And just touching on in this presentation how our technology can help address the detection of arrhythmia globally. Now, AliveCore's mission is to save lives, and to do that by transforming cardiology by delivering intelligent, highly personalized heart data to clinicians and patients anytime and anywhere. The previous presentation touched on the variability of survivability of cardiovascular disease. We want to level that playing field. Our company was founded by this gentleman on the right, who a number of you might know, Dr. Dave Albert, commonly known as Dr. Dave. And he developed the first iPhone case that worked as an ECG back in 2012. And since there, the company has just kept growing. AliveCore is now over 200 staff, and we're developing cutting edge artificial intelligence and machine learning technology, devices and platforms to support heart health worldwide. And the driver for this with Dr. Dave, who's a cardiologist, is the fact that heart disease is responsible for more human deaths than any other cause. Almost 2 million annually in the EU and 31% of deaths worldwide. And actually, in half of the mortality cases, the first sign of heart disease is cardiac arrest. In Europe, that's 275,000 out of hospital cardiac arrests annually, with survival rates less than 10%. So the detection of arrhythmia and the appropriate treatment is key. And atrial fibrillation is one of those arrhythmias, and it can lead to a significant increase in the risk of strokes, blood clots, and other heart-related health issues, with over 40 million people across the world having it. So this sort of gives a bit of a line of our products, where we started from on the left with the iPhone case, to then the separate single lead device, to then the 6-lead device. We move through some apps for patients to improve their heart health. In America, we've launched a credit card device that is coming soon internationally. And then excitingly, on the right-hand side, this is being launched for over 18 months in the US, and again next year is going to be launched internationally. That is a 12-lead ECG. This was designed to bring a truly portable ECG device that can be used remotely in areas that traditionally have little access to ECGs. Slightly larger than a box of matches. It contains 2 AA batteries and can take 1,000 ECGs, and is simpler to use than a traditional 12-lead because it has a single lead with just 5 electrodes. And with that, it's able to measure 4 electrodes, interpret 4 electrodes, and synthesize 4 electrodes. But as I say, that's coming soon next year. Being so well established, we've got a lot of experience, and a lot of people have used us. Over 3.8 million in the lifetimes of the products, and that leads to a lot of people who are using us on a day-by-day basis. We're currently regulatory approved in 43 countries, and I will put a list of those up at the end of the presentation. Again, these figures can almost be updated on a daily basis. We've now got over 300 million ECGs have been recorded with KardioMobile devices, over 150 patents, and we are the most clinically validated personal ECG with over 222 peer-reviewed articles. The simplest device we have, the KardioMobile, it's a single lead rhythm strip comparable to lead 1. And in 30 seconds, it can do an instant analysis for normal sinus rhythm, atrial fibrillation, bradycardia, and tachycardia. Importantly, we are a medical device, and we are regulatory cleared for its use as such. Our 6-lead device, what you can't see here, has a electrode underneath it, and that enables you to create Einthoven's triangle. So we can reproduce the limb leads 1, 2, 3, AVF, AVR, AVL. We have the same AI overreading regarding arrhythmia, but getting greater views of what is going on with the heart electrically allows you to actually interpret those 6 leads as well. And we see really our role to be the sweet spot between short Holter monitoring, be it 24 or be it 72 hours, and sort of implantable loop recorders. We're a device that you can lend to a patient or an individual for a period of a couple of weeks or a couple of months. And when they when they are feeling symptomatic, they can take an ECG at that time and either email that ECG or take their smartphone to their next physician appointment and show when they were actually having symptoms, what the heart was doing, or what some practices are currently using is our Cardia Pro software. And this is a laptop, desktop based platform that actually allows you to create a connection with a Cardia mobile device. So every time that patient takes an ECG, it is automatically brought into the Cardia Pro for later review by the physician and classified by the AI again. So it streamlines your data flow. Now, all this is based on clinical research. On the left, we have the investigation of palpitations in the emergency department compared to standard of care at the time, Holter monitoring. With the detection of paroxysmal AF, how did actually CardioMobile do? In the center, is a study that compares our 6-lead device against standard 12-lead device for the monitoring of QT interval. And on the right, that's Astrid Herman's study, where it is looking at CardioMobile versus Holter AF recurrence above ablation. These are just some of the studies we've got behind us. But importantly, we have sufficient data in the detection of AF that we were given at the National Institute of Clinical Excellence MTG tag 64, which recommends CardioMobile for detecting atrial fibrillation. And that makes us the first and only NICE recommended personal ECG. The highlights from that report are that the clinical evidence shows that significantly more people had AF detected using CardioMobile compared with Holter monitoring. That was 5 times more individuals. And importantly, it showed it was detected 10 times quicker. So it's easy to use, can be used anywhere at any time of the day, well suited to ambulatory monitoring. We've also actually had an early value assessment for the use of measuring cardiac QT in adults having antipsychotic medication. The access to and the patient acceptance of 12-lead ECG in psychiatric services can be difficult. And so this was a nice recommendation that you can use the CardioMobile 6L to get that information. It was sort of picked out that with the less need for undressing and the fewer conductive stickers or gels made it a lot more comfortable and easier to use than the 12-lead device. And actually, we find that in other areas where QT needs measuring, for instance, QT prolonging anti-cancer treatments for breast cancer, the actual privacy and dignity over having to use a CardioMobile 6L versus a 12-lead is highly appreciated. So CardioStation is our professional level piece of software. If you want to do screening to identify individuals with undiagnosed AF, CardioStation would be the piece of software to use, and that can be used actually alongside a QT measurement using an EK12 algorithm by GE Healthcare. If you use it in that format, we call that instant QT. And that allows rapid monitoring after just 30 seconds of the arrhythmia and having the QT actually determined as well. And what I can do here is just play a very brief video of how that functions. There is no sound. This is creating Einthoven's triangle. You go straight into getting the ECG of leads 1, 2, 3, AVR, AVL, AVF. And here, this slightly sped up, but as you can see, you get QT, QTCF, QTCB, and RR intervals. So if you're making medication choices, you can be informed about that individual's cardiac health. Now, this is just a quick overview of the survey of 417 physicians. At the top, it's split into ECG-based devices on the white background and PPG devices on the grey background. And it just looks at the devices out there, who uses what, who recommends what to physicians, to patients, or hasn't heard of the device. And as you can see, 3/4 of the way up that table, Cardia and Cardia Mobile 6L do very well and are well represented. And clinicians recommend Cardia because it's convenient and suitable for short or long-term monitoring, gets patients engaged. It allows early detection, but it gives immediate feedback. So patients can either have peace of mind or know that they need treatment and can monitor how that treatment is progressing. We're accredited, and this is mostly European. Apologies for anyone further afield. And from a clearance perspective, these are the countries where we have regulatory approval for for sale of our products. And this is my final slide. If you'd like to know any more, you can scan the QR code on the right of the screen, and that will take you to our website, or on the left, that is OUS Enquiries at alivecall.com. And myself or another member of our team will be more than happy to come back to you. Thank you very much.
Thank you so much, Andy, for keeping in time. But more importantly, I think it is just a quick one-line message from you. What's next for AliveCore? What are we looking in 26, 27 that will really change and make it easier for people to look at their ECG or pick up their ECG quickly?
I think there's two things. The first thing is the 12 lead, and where that takes us is at the moment we're limited to arrhythmia. The 12 lead is when it comes out, we'll have 40 determinations of morphologies and arrhythmias. So it's opening up what the physician can see in the patient. But importantly, the next step for us is actually to democratize and get more of that information out there in the patient's hands, so they're more easily able to take highly accurate ECGs of themselves that give more information to the physician.
Perfect. No, I mean, it has already been a game changer. I can tell you that I was on a flight to India 6 months ago, and there was a patient on board starting getting chest pain. I had my cardia with me, and it did an ECG straight away on the plane. The pilot gave me special Wi-Fi. The device, everything was open, but obviously it was not a heart-related pain, so the patient was well saved, and he landed safely in India. But definitely, it's a game changer. It is helping a lot of patients in UK, Europe, and globally. So well done to the team. Thank you so much, Andy, for your support to the conference, and we look forward to keeping in touch.
An absolute pleasure, Ray J, as always. Thank you.
Thanks so much. Take care. With that insightful discussion with AliveCore, I'm now very privileged to introduce to you our next speaker, Professor Partha Kar, OBE. He's a consultant in diabetes and endocrine at Portsmouth Hospital University Trust and ex-national advisor to the diabetes for the NHS for diabetes. He's a globally influential voice in diabetes transformation. Professor Kar has personally pioneered several initiatives at a global level, including Super 6 diabetes model hailed by the King's Fund. Especially he co-led the national Getting It Right first time the GIFT diabetes program. And again, he's a guru for type 1 diabetes in glucose monitoring, leading many of those initiatives, championing many of those technology around the world, which is making the life of diabetes patients completely different. He was honored by the Queen in 2021 with OBE. He's also again a very big voice in the BMJ and HSJ. So Professor Kar is especially joining us from India. So Professor Kar, thank you so much for joining us all the way from India. And your topic is on paradigm shift in diabetes management and what is we going to see in the future ahead. So thank you so much, Prof. Kar, for joining us.
No, my absolute pleasure. Hopefully the Wi-Fi is working okay. That's always the biggest challenge.
Yes.
So I've shared my screen, and I
You
just
can
wanted to
see.
say, Raja, what a wonderful conference you and your guy, everybody is organized. So hats off to you. which is why it didn't matter whether I was in India or not. I think I just wanted to make sure my Wi-Fi was okay. So
Thank you
hopefully
so
it
much.
goes okay. All
Thank
right. So
you.
what I'll do is I will just give an overview of what has happened in the UK setting across time and what impact does technology actually have in the world of type 1 diabetes. So to start off with, in 2017, so about 7, 8 years ago, this particular device had just arrived. It's called a continuous glucose monitor. And so forget too much of the detail, but basically the continuous glucose monitor is a step ahead from you have to prick your fingers and now you could actually see it on your phone. In those days, the uptake was really low. We had insulin pumps, that uptake was low, and we didn't have a national type 1 diabetes audit. So lots of things that happened. And type 1 diabetes outcomes of the UK were quite ordinary compared to most comparable European countries or definitely America, etc. So we were challenging ourselves as to how we could look at those things differently. And this was a problem we also had in those days. As you can see, as Rajay mentioned, one of the things I do is going around tackling variation. But you can see the issues here that you also, first of all, the uptake wasn't high. And even if it was high, it was skewed based on, as you know, any technology comes, we always talk about this, based on the color of your skin or indeed your deprivation. So that was a big thing. And I just wanted to make a note of this one. That if you look at the orange one is where we had started the data collection. A black child had half the chance of a white child in the UK when we have an NHS, which is supposed to be equal for all. So that was one of the big challenges we had. We had technology coming out throughout the globe, and it, however, didn't seem to be having the impact of getting into people's lives. But where are we now? So if you look at it now, 25, this is data from about March 2025. So if you look across the ages, you can see what's happened, especially look at the last column. Nearly 80% of people with type 1 diabetes have got some form of technology. Now, if I can take a pause and basically to explain everything, is that type 1 diabetes in general has three parts to it, which is you prick your finger, you look at a number, you do some mental maths with the number, and then you decide whether to give yourself insulin or glucose. And finally, in most cases, you give insulin or not, depending on your mental state, etc. Because it's so repetitive and it has to be done so many times, it's very difficult to get on top of things globally. What technology is trying to do is automate most of those things. So can the finger pricking be automated? So it becomes right now what's happened is that your glucose levels are always available on your phone. You can make any changes you want. You're very aware of what's happening on alarms to tell you if it's high or low. And what we do have is a system, which I'll come to in a minute, which also automates in the majority of cases how insulin is delivered. But this is some of the proud thing that's happened in the last 8 years. You remember I showed you that difference in black child and white child, about half, but this is where we are now. So you can see by March 25, there are absolutely no gaps in deprivation and literally very, very little based on the color of your skin, which we're very proud of because we've been able to really raise the bar in access and getting it, not only getting it out there, but getting it equally, irrespective of your ability to buy or pay and irrespective of the color of your skin in a proud moment for us going forward. Sorry, skipped one. And this is also the deprivation gaps, which have closed over the course of time. So it's taken time, as you can see, a good 6, 7 years, but we've got there. But here are some outcomes as to what that's achieved. And this is really important. This is pregnancy. And if you're pregnancy in type 1 diabetes is notoriously difficult simply because we are asking people to check their blood glucose about 10 or 12 times a day, which, as you can imagine, a mother with lots of issues going on, asking them to check their blood sugars 10 times a day, finger pricking was going to be really, really tricky. But ever since we have started to see what's happened, the serious adverse events, this is all patients with type 1 diabetes in this country, and this is all pregnancy. You can see that coming down, the congenital malformations coming down, the serious adverse outcomes coming down, which as a population has been really, really heartwarming to see. These are hybrid closed loops. So hybrid closed loop is what I said. It basically automates the whole thing. And this is what we are doing across ICSs, or as we call it in UK, the little systems of bodies, so areas. There are 42 of them in the country. In London has got 5 of them. Then up in the north, they've got another 6. So it's divided across the country. So hybrid closed loops is what I would say is automates the whole system. If you remember what I said about how you check your glucose, you have to make some mental maths and then give yourself some insulin. What is happening with hybrid closed loops is that your pricking a finger is not there anymore. The sensor picks it up. The number is then Bluetooth across to a delivery system, which has got insulin, which has got an algorithm which does most of the mental maths for you and delivers the insulin. So you can imagine the change whereby technology is doing majority of the self-management. So this is what has happened, hybrid closed loop. You can see in children's, I can tell you as of the most recent data, which came out yesterday, as of end of September 2025, we started using hybrid closed loop in this country from April 2024. So about 18 months, that number is now up to 71%. So the vast majority of children in this country very rarely will prick their fingers or use insulin, which is a massive paradigm shift. And we are very proud to be one of the few countries in the world, if not one of the top countries in the world, to be able to provide this at that scale. But what has it done for a population? Here is an example of what it's done. Those bars are the amount or the percentage of children with an HbA1c below 7.5%. And those of you in this world will know the value of that, trying to get good glucose control. And you can see the steady rise. The CGM is a continuous glucose monitor, got introduced in this country in 2018. And then 2024, you had the next one, which is the hybrid closed loop or the artificial pancreas, as the media terms it. And the most recent data now has about 58 or nearly 60% of all children with an HbA1c less than 7.5. What we're trying to do is a whole population shift across the bar and bring everything down. This is what has happened in adults. You can also see the trend down, but there we do have gaps in deprivation, which we have to tackle. What we also do have is overall as a country, our ketoacidosis rates have gone down, our hypo rates have gone down, which again isn't surprising because of the automated nature of it. So we are one of the few areas in the NHS where we have been able to implement the NICE guidelines pretty much at scale, which has been very, very proud moment for us. And most importantly, across deprivation and across ethnicity issues. So in summary, what has happened compared to 2017, continuous glucose monitor is now standard care in type 1 diabetes. More than 90% of people are using it across the board. The only group in which we see fall off is the age above 75 due to many reasons, and that's technology, inability to understand and carer, education, etc., which we're trying to tackle. Hybrid closed loop is now standard care in type 1 diabetes for children, and which is exciting because there's no other country which can at the moment claim that, bar in fairness Sweden and Belgium. So not many countries can say we're providing this at a high level of 70, 71%. We have the best HbA1c outcomes since records began, and drop in DK and hypo. So really, really good with some areas to tackle. So that's a very short, sharp run through of a population change of type 1 diabetes. How's that?
Thank you so much, Prof. Sarkar. That's very, very insightful. We're getting lots of questions, especially on YouTube and other social media platforms. What's there for India next? Because, India is possibly going to be the diabetes capital of the world. We are seeing lots of patients with diabetes in India.
I can give you a very good I'll give you a very good answer to that, because tomorrow I'm actually traveling to the big Indian conference, the RSSDI in Kochi. That's
Yes.
where I'm traveling tomorrow. So I've been working in India with different governments over the last 2 years, and we are very, very positive. We can give you some good news that in West Bengal, for example, we've got 16 districts covered now with type 1 diabetes clinics. We are just about to announce that in Uttarakhand. Maharashtra has taken interest, and also in Rajasthan. I'll be very honest, there are two in need to realize. There is an India of Shah Rukh Khan and IPL, and which is India. It can afford everything. And there is something called Bharat, which really struggles to afford anything. So our job is to try and how do you work with governments? It's a very federal system in India. So you have to work with state governments across the board to try. So we're working on it. And tomorrow's meeting that I'm going to is to meet all the big stakeholders and all the sort of big champions in diabetes in India, like Dr. Mohan and Banshi Sabu and Amit Gupta and all, and Jyoti Dev and everybody, to try and see what we can do further. So no, it's one of my core things to try and give back to India as much as I can. To be honest, that's why I'm here. So yeah, that's definitely
Absolutely,
on the
absolutely.
angle.
But do you think a future where in the coming years we will have cheaper devices with for glucose monitoring, where most of the Indians because 60% of India's population is in villages, well, they'll be able
So
to afford it.
100%, 100%. So I think right now, so one of the big things is that the good encouraging thing is that we have met some Indian companies developing it. So the question is now to get the integrity in there to make sure the device is good, because we've had some devices from China, but that has not been always very good. So I think if we can produce it, so example is Rajay is, we've got generic SGLT2s and everything in this country. Can we get that sort of sync system into technology? I think the answer is yes. In India, can pretty much produce anything it wants nowadays. It puts a head to it. So hopefully, fingers crossed, yes, we can.
I'm sure if you are putting in so much effort, it will definitely lead to more changes in lives of not just in people in UK and Europe, but also in the Indian subcontinent. So thank you so much for everything that you do, Prof. Carr. And
Pleasure.
thank you so much for taking our time to join all the way from India. And we look forward to keeping in touch. Thank you so much.
Absolutely, my pleasure. Take care.
Thank you, sir. Take care. With that insightful discussion and the groundbreaking work that Professor Carr is doing in the world of diabetes, we move to another very important speaker, Mr. Dimitri Poronas. Again, he's a big name in consultant in gastrointestinal and bariatric surgery in the UK. He works at North Bristol NHS Trust Hospital. He has done lots of exciting work with the Royal College of Surgeons in fellowship and PhD from Imperial College. He has also led several initiatives related to obesity, because we know obesity and diabetes are going to be one of the biggest challenges that we face here in the UK. He has also been part of the Metabolic British Obesity and Metabolic Surgery Society, Royal College of Surgeons, England's specialty lead. And again, he's a visiting professor for University of Sunderland, and has authored, in fact, more than 100 peer-reviewed publication in the Lancet and the BMJ and other important journals around the world. So he is going to talk today on the future of bariatric surgery in the new world, and what role do robotic innovations, combination therapies, pathways, life transforming metabolic health systems play. Because as we know that obesity is again hitting a big number across UK, across Europe and globally. So thank you so much, Mr. Pranas, for joining us, and we look forward to hearing you.
Well, thank you. Thank you for having me, and thank you for the very kind introduction. I'm trying to share my screens. Can you see them?
We can see yours. You can do a slideshow now. We can see it.
Amazing. Thank you. So I'll be talking to you about the future of bariatric surgery. This is Southmere Hospital, and I have to say I'm not a professor in Sunderland, but I do work around the world, and I do visit India very often. And so from a global health point of view, I see obesity in different parts of the world. But I also sit outside the obesity clinic. This is my conflicts of interest. I work with a variety of organizations in this complex space. But perhaps my most important conflict of interest is that I am a full-time surgeon. I work as a GI surgeon in the elective and in the emergency setting. I'm actually currently on call for the major trauma center, which is why I'm not wearing my suit and tie. Unfortunately, emergency surgery got in the way. But what I'm trying to say is that I see obesity outside the obesity clinic. And I want to start by talking not about bariatric surgery, but about gallbladder surgery. All of you will know someone who's had a cholecystectomy. It's one of the most common operations performed worldwide. And I want to ask you, what do you think is the risk of death from this operation? You know, if a friend or a relative asks you, or a patient asks you, what is the risk of dying? I'm just going to show you some data from the UK. This is not clinical trials. This is real life data from our surgical trainees did this across the country, 8,900 operations, almost a decade ago now. And you can see the complication rate, 71%, and the 30-day mortality is 0.15%. It's very low, but it is at 0.15%. And now I want you to tell me or think about this. What do you think is the risk of bariatric surgery? What is the risk you would quote from someone dying during a bariatric surgical procedure? And what I'm going to show you next is the number in the UK at the same time. This is again not from clinical trials, and you all know clinical trials are a happy place where everything goes very well, and of course there is a lot more resources involved. This is again from our National Bariatric Surgery Registry. And what I'm showing you here is that the risk of death from bariatric surgery in the UK at the same time is 5 times lower. And I do both of these type of operations, and I can tell you none of my patients ever get told that they may die from bariatric surgery. They may die from a cholecystectomy, but they always get told they may die from bariatric surgery. And the truth is that it's much safer to do bariatric surgery. Of course, it has to be done in high volume, high frequency, high specialized centers. But what I'm trying to show is it's extremely safe. And actually, the updated results, if you look at our current data from the registry, it's even lower than that. I'm going to share some thoughts on why obesity is a disease and when you treat it as such. As you know, we take a global health viewpoint. The only country, and I used to say no country has ever reduced the impact of obesity. What we have seen for the first time in decades now is a stabilization, a reduction in BMI. That's not a reduction in prevalence of the disease, reduction in BMI in the US, and this is driven most likely by the available pharmacotherapy. There's also this misunderstood causes and complications of obesity. People very often think it's a simple disease, and this is not modern art. This is a slide of pathways, and if you zoom out, if you zoom in really in any of those pathways, you'll see why homeostasis is so robust around obesity. And this is why for a very long time it has been very challenging to treat. This is the reason why most of us have kept our weight stable in the last 12 months, although we have had days where we have had very high intake in terms of calories, and we had days where we've been running around, we've been on call, busy in clinic, we have very little intake. But our variation in the last 365 days has been very wide in terms of intake, but the variation in our weight is actually exactly the opposite. It has been very stable, unless we have been intentionally trying to lose weight. And of course, I would say that every disease is not people's fault. It's just their responsibility to get treatment. And very often we stigmatize against this disease called obesity. And I would say that the historians of the future will look at how we treat obesity today, the way we look, and we are surprised about how epilepsy was treated 100 years ago, how HIV was treated 35 years ago. And with the progress in science, what we do is we destigmatize the condition, we understand the disease, then we start treating it better in a much more focused way. Our treatments become safe, effective, a lot more focused, and a lot more available, just like HIV has been treated globally, and a good example of a global health challenge that has been addressed very successfully in the last 3 decades, very, very rapidly. And we can do the same thing with obesity. And finally, we need to separate prevention and treatment. And very often when I talk about bariatric surgery, people say, why you don't talk about the food industry and the regulation around our food intake. And of course, these are very important aspects. And I work in a major trauma unit, and I can tell you that please wear your seatbelts, please wear your helmets, makes a big difference. But when we progress our trauma care, and the patient who perhaps is in my emergency department today after major trauma with a Glasgow coma scale of 6, what they need is to be intubated, a CT scan, and to go to the operating theatre so we can save their lives. What they don't need, and they're not going to get any benefit, is us telling them they should have been wearing a helmet or they should be wearing the seatbelts. What we need to do is we need to go out in the community and try to do this at a global level. But these two aspects of care, these two aspects of our career are not conflicting. They're complementary, and they should stop. One should not stop us from doing the other. And for those of us who are in the treatment space, we need to continue being focused on the treatment space. More importantly, even if we do get the most amazing prevention strategies today, and I have to say there is a paucity of randomized controlled trials that demonstrate a significant benefit at population level for our prevention strategies, we will still have people who have the disease today, and therefore they will not benefit from the prevention strategy. A lifestyle intervention for those people who have the genetic makeup that allows that to work. And of course, if you're leptin deficient, you will get obesity no matter what the lifestyle or the environment is. For those people will get, if we do through a good lifestyle intervention, they will get a benefit from reducing the risk of obesity. But if they have the disease, this intervention is not going to have an impact in the long term. And as you all know, if you look at the clinical trials, the vast majority of people who respond to a lifestyle intervention, when the BMI is over 35, over 40, the recurrence of the disease is in the very high 90% at 5 and 10 years. So it is not really effective in the long term. So we need to change the language, and the experiment I always use is that, I may have a high blood pressure today because I'm talking to all of you, and I'm also sort of working clinically, and maybe my systolic is 200, and you may say I am hypertensive. But if I had that a year ago, and I'm now on very good treatment, and of course this is a cardio-renal metabolic sort of session, I would have good control. And if I ask you if I'm hypertensive, you may say yes, but I would argue that's not correct because I'm normotensive. My systolic is now 120 and my diastolic is 75, but I do have the disease of hypertension. So my patients will now have a BMI of 25 after treatment for their obesity with surgery or pharmacotherapy. They still have the condition called obesity. So language does matter. It's for accuracy, and it's also not just for being kind to people and for destigmatizing the condition. It's also for being precise in our communication with each other and with our patients. We need to understand the heterogeneity of the condition. Of course, we treat obesity as one disease. It's very, very heterogeneous. It's a bit like treating colorectal cancer, breast cancer, and pancreatic cancer in the same way. Forget about treating T1 and T4 disease differently. And this is the largest series of runaway gastric bypasses in this country. It's about 2,000 operations in the southwest of England. And what I really want to show you is that every patient is a black line. You see some people do really well, some people do below average. Most people are around average. And those people who do really well are not morally superior. They just have different biology. Just like the people who do really well and respond really well to chemotherapy are not morally superior. They're not more motivated. They have different disease and different biology. And that is true for any obesity treatment. This is a model of other treatments. This is a diet. It's using an example of low carbohydrate. And what you see the normal distribution, just like any other biological phenomenon. This is liraglutide, the first generation of GLP-1 receptor agonist. The new generation of medications, they shift this curve towards your screen right, but it's still a curve. And some people do better, some people do worse. But this is biologically driven. This is endoscopy devices that do a jejunal liner, which is just becoming available again. And this is surgery. So what you see is that whatever you do is a biological phenomenon. It's not mechanics. It's not engineering. It's not that everyone gets the same outcome. And you would expect that from any other treatment for any other condition. Obesity should not be different. We need to consider all treatment options. And again, obesity is singled out as a disease where people come to us, they've been on diets. I have patients who not only understand diet, they have written books about the diet, and we tell them to go back and do yet another diet and expect a different outcome. And that is a violation of common sense. And of course, it's not good clinical care. We need to stop the treatments that don't work, replace them. The first thing we do when chemotherapy doesn't work is we stop it because all we get is side effects. The same needs to happen for obesity. And this is one way of doing this. This is Lee Kaplan's model, and I'm completely aligned with that. Self-directed lifestyle change. The lifestyle intervention. If that doesn't work, pharmacotherapy, patients not responding to that or can't tolerate that, bariatric surgery, and then combine surgery with medication. Use multimodal treatment, just like we don't talk about patients getting either chemotherapy or radiotherapy, they get a combination. And I'm trying to demonstrate that with some modern art. You can see that both of those works of art in Tate Modern in London. This is Damien Hurston. You can see medications and surgical instruments. So I'll start concluding by saying that obesity needs to be treated as a disease. We need to stop debating if it is or not. We need to treat it as a disease. And that's what I do in my current practice. And this is what will become the standard of care. We need to use multimodal care as we do for all other complex conditions. These are the people I work with, and I'm very grateful to them. And what I'm trying to demonstrate here is that the pace of change is extremely rapid. And right now, we have the worst obesity medications we will ever have, and perhaps we have the worst bariatric surgery we'll ever have. But as you can see, they're extremely good, and we need to use them. Things will only get better. This is the last flight of a Concorde ever. This was the last landing. It is going over Clifton Bridge, which is just around the corner from where I am at the moment. And you can visit the Concorde in Bristol. This is the last Concorde that ever landed. And you can see a lot of people have gathered to see it. And I'm trying to demonstrate that the pace of change is really supersonic. Thank you very much for listening.
Thank you so much, Mr. Pranad. That was very, very exciting, especially the last few exciting slides talking about the combination therapy and the fast pace at which the obesity is changing. Because when I was a junior cardiologist, registrar, or training as an SHO, we never talked about obesity. But the cardiometabolic clinic that we run at St. George's along with Dr. Chen, we are seeing so many patients with obesity. We're talking so much about obesity. We are not just talking about cardio-renal metabolic, it's cardio-renal metabolic obesity. We also have now an European Society for Obesity, which again is coming up with lots of guidance, pathways on treatment strategies. But the numbers are going up in hundreds and thousands globally. We have already, I think, slightly late the way we started, but again, there's a steep curve that are ahead of us. What is one thing that the government of UK, Europe, European Union, or the global governments in different countries can do to stop this pandemic from going even bigger, because it is getting out of control? We are seeing so many patients on a regular basis.
So absolutely. I mean, I would say that we're not in the rare diseases sort of space here. We're dealing with, we have parts of the world where the majority of people have overweight, live with overweight and obesity. So absolutely. And I think we just need to remember that we, as a generation, are now used to pandemics. We know how quickly they work out. So if we do throw resources at it, COVID-19 was an obscure virus in March 2020. And within a year, we had a vaccine, we had a test, and we had clinical trials that reported in real time. Recovery trial, a trial performed in the UK, it was one of those trials that reported at breakfast, and by lunchtime, practice. So we can do that if we actually resource it appropriately. And I think for obesity, we need to do exactly the same. So my plea to governments is to take it seriously. We are not. There's not a single government on this planet that is taking the disease seriously. We all talk about it, and we all talk about the projections. And very often you hear people saying, oh, by 2030, we don't need to project. Actually, most of the projections are underestimating what's happening. We know, we can measure, we don't need to project, we know what's happening. And we need to do two things, just like we do for most conditions. We need to focus on prevention so that the problem becomes smaller. And this is what we did with masks. And this is what we did with PPE. And at the same time, we need to treat. And we need to invest for treatment, because the most expensive way of dealing with obesity is not treating it.
Yeah.
And
yes.
obesity, as you know very well, and you run a world-leading unit around cardiometabolic risk with Mimi, is that it's obesity doesn't kill on its own. It's a bit like diabetes.
Right.
People don't die of blood sugars. People die of complications.
Complications.
Heart attacks and strokes. And obesity is exactly the same. So we need to treat it so that we can reduce the cardiovascular risk. And we have the data now. We had the data from bariatric surgery for many years. We know that by treating obesity, not only will we reduce cardiovascular events, we know that we also reduced cancer mortality. So not doing it, the most expensive option is what we're doing today around the world, which is not treating it.
Correct. No, thank you so much, Mr. Parnas, again for joining us. We'll be definitely taking all your key messages from the talk as part of the document that we are creating that will be submitted to the WHO, UN, UNDP, and the various countries around the world. And we'll definitely keep in touch for your guidance in this field. Thank you so much again for joining.
Thank you for having me. All the best.
Thank you so much. With that, ladies and gentlemen, we move on to our next speaker. Again, we don't need more introduction about the next speaker, who's Dr. Mimi Chen. She is a consultant endocrinologist at St. George's University Hospital in London and a senior lecturer at St. George's University. She did her PhD from Bristol University. She has set up UK's first cardiometabolic clinic in the NHS in September 2020. We are about to publish data from that cardiometabolic clinic, which Dr. Chen has been leading. She's also been principal investigator for several landmark weight management, diabetes studies, trials, and papers. So thank you so much, Dr. Chen, for joining us. Dr. Chen is going to speak on challenges in diabetes management, from lifestyle to social determinants, the challenges ahead, and what do we need to do really, because we know that heart, kidney, diabetes, especially diabetes in the developing countries like Indian subcontinent, are going to be one of the biggest challenges, the global health challenges that we're going to face. So over to you, Dr. Chen. Thank you so much again for joining.
That's all right. Thank you so much for that brilliant introduction. I hope I can live up to the expectation, and I really enjoyed the talks. Hi, Dimitri, if you're still online. So this is actually a really good follow-on from Dimitri's talk, how to break the barriers in the diabetes management. So interestingly, Dimitri just said about the prediction, and this is a fact, evidence-based. And what we predicted in 1990 is to say, oh, we're going to have these many patients. However, we're not even there yet, talking about 2050. 2050, what's the prediction will be, because we're already gone beyond prediction in 2022. So there's a huge surge of diabetes, and part of the reason is because of the obesity. As you know, one of the biggest risk factor for type 2 diabetes is obesity. So by not treating obesity, you're not just talking about weight, you are actually leaving your patient open to many other conditions, and including diabetes, cardiovascular disease, and also kidney disease. So I'm not going to talk too much details in what diabetes is, what the treatment is, but we want to introduce a relatively new concept to the world, but for us since 2020. So diabetes causes blindness, kidney failure, heart attack, stroke, and lower limb amputation. And this should be common knowledge now for healthcare professional. And in 2021, which is not that long ago, 4 years ago, diabetes and diabetes kidney is the reason that leading to over 2 million deaths worldwide. And also we talk about cardiovascular disease. One of the huge contributing factor for cardiovascular disease is high sugars. So what is the landscape in the UK? So in the UK, we have the prevalence of diabetes is over 4.5 million, and it is growing as we speak. And this has a huge impact on the NHS from a costing point of view. We spend 10 billion annually to deal with management of diabetes. And the impact on individual is also really, really high. This is quality of life, disability, premature mortality. So diabetes is not a trivial disease. And we always joke about this. People like to say, oh, it's mild diabetes. There's no such thing as mild diabetes. If you have diabetes, you affect every single part of your organ, and you can double your risk for cardiovascular disease and many other diseases. So the treatment is lifestyle, and people are just poo-pooing it and saying, oh, we don't really want to do the diet exercise, and because it's too hard, we want to have new medication. And guess what? For every single trial, you're looking at a effective medication. The background is always lifestyle modification. If you just take your Mounjaro, Wegovy, or Ozempic for your diabetes control, for your weight management, if you don't do the lifestyle modification, the success rate is much, much lower. So when you read a peer-reviewed journal, and when you see the quoting of 10%, 15%, that is all on a background of lifestyle modification. That means diet, that means exercise, and that means weight management. So here I would like to introduce I wouldn't want to say it's a new concept. It's always been here, but it's more to increase our awareness. Many people will say, oh, this person have 10, 20 comorbidity. This is what we see in cardiometabolic clinic and also cardiorenal metabolic clinic. But really, there's one thing fundamentally wrong with the patient for all of those 20 comorbidity, and that is the obesity, metabolic dysfunction. Because think about obesity. What can it not cause? And so basically, think about this. If you have obesity, metabolic dysfunction, this is where you can get cardiovascular disease, you can get diabetes, you can get kidney disease. So really, diabetes is the primary driver, not just as a comorbidity. Managing your weight in a more holistic way, and then you can address every other diseases. There's a lot of barriers to do this because we're human. We're not in a research trial. We're not actually taking time off and stay in a bubble. We have jobs, we have families, and we have our own, problems. So all of these things affect how effective you can do your diabetes care. So if I just have a patient walking into the clinic and then I would just say, well, get your sugar right, without asking them, how's their life? do they have problems? How's their work? How did they get here today? And do they have financial problems? All of these affect how you look after a patient and in their diabetes care. So it's not just about this person does not want to look after themselves. It's very much how do we get people to the right place despite the depression, despite financial constraint, despite their old age, ethnicity, or socioeconomic status. So this is what we do in the cardiometabolic clinic and also cardiorenal metabolic clinic. We have a holistic approach, and so we're no longer glucose-centric. We don't just jump in to say, how is your sugar? Oh, that's really bad. Can you take this medication? Can you take that medication? The best medication is the medication that the patient take, and also on a background of lifestyle modification. So this is, I stolen this from one of the orthopedic journal, is the Life Simple 7. What does that mean? We can't just focus on heart, and we can't just focus on kidney. We really need to focus on everything that will affect patient developing all of these diseases. And everybody can do this. Before, we're always very focused on, if you come into a cardiology clinic, we're always going to talk about your heart, nothing else. Come to diabetes clinic, only the sugar, nothing else. But what we're really trying to do is to get everybody, every single health care professional to address all of these. If you talk enough about stop smoking, if you talk enough about weight management, your patient will actually register to say, oh, if I lose the weight, then that means my heart is getting better, my sugar is getting better, my blood pressure is getting better. So why not? And this is the important concept of a holistic approach to diabetes care. And we would like to extend that to the whole treating metabolic syndrome. So I addressed heart, kidney, and metabolic, so diabetes. This is not about just the sugar, because if you address one thing, which is your weight, and you optimize your diabetes, then you have much better outcome overall, not just one organ. All of you is going to get better. And and remember how we always say, if you have diabetes, you're double, triple your risk of cardiovascular disease. However, if you have the perfect control, never smokes, moderate amount of alcohol, and lose weight, and sugar is right, then you're going to reduce that risk. It's not that everybody, just because you have diabetes, your risk increase. It increases because of all the risk factors has not been addressed. So not just one thing, everything. And in these days and age, we can't just talk about diabetes without talking about how to utilize your technology. And that could mean a continuous glucose monitoring for those people who are very busy. They may say, oh, I can't really be bothered to take my needle, take my monitoring, and prick my finger in the middle of a talk or in the middle of a conference. But this is what happens. We need to start thinking about how can we enable our patient so that they're not just being told, do this. What can we do to make their do this much, much easier? So can we offer them a remote consultation, personalized feedback, digital access? Because many people who have jobs, full-time jobs, live in a rural area, it may take them 3 hours to come to your hospital. And having all of these, that means they don't have to travel every 3 to 4 months, but they still can look after their diabetes, and they can still get hold of the expert opinion. And this is across the world. So I've only talked about UK, but across the world, there is disparity in diabetes care, the quality of diabetes care. And this is such a huge strain on healthcare. And so you can't just wait for the person to come to your hospital to say, now I'm going to address your diabetes. It has to be done by everybody. So we're going to do it together, do it in the community, and we get the advice from the specialists. They may be based in the community, and they may be based in the hospital. And the smart way to go forward is a multifaceted approach. And this is why what I want to stress the importance of integrated care. We should not work in silo anymore. We should work with our cardiologist, nephrologist, bariatric surgeon, and respiratory consultant. We need to get everybody together. And whether it's primary care or hospital specialized care, we need to start addressing everything rather than just your single organ approach. And this is also very important that we talked about policy changes. Until the policy changes, until we have the cross-sector collaboration, it is really difficult to have one person flagging the flag to say, I would like to have a cardiorenal metabolic clinic. But really what we want is for people to understand this approach. So just because you're not in this specialized clinic, you can still do the things we do. We want to scale everybody to say, do this to improve your patient care. And we should also looking into the future because at the moment, with the financial restraint, we always focus on what's in front of us. But really, we need to also look into research to look at tailored intervention, to look at improving health literacy and also reducing the health inequality. And so this is the end of my talk. So if there's anybody having a question, please put it in the chat box.
Thank you so much, Dr. Chen, for that fantastic talk, as always, and addressing that, holistic approach that is required in managing cardiorenal metabolic. Your colleagues spoke earlier, Dimitri Parthakar spoke from India just now. We had the president of the European Society of Cardiology, Professor Lushka, speaking, and again, all of them saying similar things about addressing them as a holistic approach, because it's not just heart, just kidney, just diabetes, just obesity. All of them have to be addressed holistically. What is that one thing? You're getting lots of questions on YouTube, and possibly we'll have to send it to you because we are running short of time. But just wanted to ask one thing that the UK government needs to do in the field of diabetes that will be a game changer and prevent all those complications, create that awareness that is required, not just in the UK, maybe UK can be a model and then Europe can follow on. But what is that one thing that the government can do that will really make a difference in the way diabetes is managed long term?
I think it's actually to look at diabetes as a global disease and then also as a one disease that will affect all systems. At the moment, I have to say diabetes is not the most sexy disease because not as sexy as cardiac disease, I have to say. But if we can focus on to say, if we can do one thing that will improve everything, and this will be, my ask to highlight the importance of managing diabetes properly.
Thank you so much, Dr. Chen, again, and we look forward to keeping in touch with you. As I mentioned earlier, that we'll be making notes, taking important key take-home messages from every speaker's talk, converting this into a document which will be sent to WHO, UN, UNDP, and many governments across the world, and including the Parliament here in the UK and the Health Select Committee. So thank you so much for everything that you do for us, and thank you for taking our time today.
Thank you very much for inviting me.
Thank you so much.
Thank you.
So with that, ladies and gentlemen, I'm very privileged to introduce Dr. Kevin Fernando, who is a GP in NHS Lothian, but again, more importantly, he is leading and spearheading cardio-renal metabolic medicine, especially in the primary care. He's leading several initiatives, guidelines, pathways. He's working very closely with the Primary Care Diabetes Society. He's also the co-founder for the CVRM UK. He's a global speaker on cardio-renal metabolic. In fact, this morning he's joining us from US. So thank you so much, Dr. Fernando, for joining us, and over to you.
Thank you. Thank you. Let me just share my screen here.
We can see it.
You can see it, and I'll just start the slideshow. Great. So can you see a full screen there, Roger?
Yeah, full screen.
Good stuff. Okay, thanks for that kind introduction, Raji, and good morning for me. As Raji said, I'm actually at the Obesity Week conference in Atlanta, and really epitomizes everything that's been talked about so far this morning. That multidisciplinary team approach to the management of our patients living with overweight and obesity and other comorbidities. It's been great to be at the conference this week to see a whole range of different disciplines, doctors, nurses, pharmacists, PAs, dietitians, all working together. So what I wanted to do in this brief session is just talk about how we might advance cardiovascular, renal, and metabolic medicine, some insights and innovations potentially for the future. So this is my background. As Roger said, I'm very much still working as a GP clinically, a couple of days a week, and pretty much the rest of my time is just keeping up to date. That we heard already from Dimitri earlier on, didn't we? That pace of change is terrifying, isn't it? Very exciting, but terrifying, the change in research and guidance. And it makes it very challenging for us as HCPs to implement all of this practice-changing research into everyday clinical practice. So that's been a big part of my day-to-day work. These are my disclosures, but this, of course, is a completely independent talk. I also work for Medscape 1 day a week, and I put together a number of independent resources. So I just wanted to highlight a couple of them just relevant to today's talk. So this is a type 2 diabetes CVRM, cardiovascular kidney metabolic checklist that a GP colleague and I put together, just again to illustrate, as Rajay said, that breadth of knowledge we now all require when supporting our patients living with type 2 diabetes and comorbidities. And of course, that very hot topic, the incretin therapies. That's been a big theme, as you can imagine, of the Obesity Week conference this week here in Atlanta. So again, the same colleague and I, Ema Darcy, have put together a little guide on using incretin therapies for people living with overweight and obesity. So let's talk about then CVRM. Well, there's a number of acronyms, isn't there? You may have heard over the last couple of years. CKM, as it's known in America by the American Health Association, CareMe, Carmelo. There's a whole load of them, isn't there, Roger? So it's not a new concept, is it? CVRM. It very much is the rigor these days. But actually, that relationship between the heart and the kidneys in particular has been long recognized. So I wanted to actually start with a brief history lesson, if you will, indulge me. I came across this fascinating paper from Qatari cardiology colleagues, From Heart and Reins to Clinical Syndromes, Origin and Evolution of Cardiorenal Disease. A really interesting paper and really helps set the scene for meetings like today's meeting. So, as I said, the connection between the heart and kidneys is not new. It was repeatedly mentioned actually in the ancient times, in Egyptian Book of the Dead, as you can see here, and also the Bible. And in fact, in ancient Egypt, the value of the heart and kidneys, and probably their interaction for the passage into the afterlife, was evidenced by the fact that the heart and kidneys were the only two organs left in the body after the process of mummification. Really interesting, isn't it? And then the ancient Chinese physicians used this 5 elements theory of traditional Chinese medicine to describe the relationship between the various organs in the body. Heart fire, spleen earth, lungs metal, kidneys water, and liver wood. And in Dr. Shen's Compendium of Honoring Life, a really interesting quote about the kidney and the heart. The heart resides in the vessels. It rules the kidney network, not via a controlling position in the restraining circle of relationship between the organ networks, but simply because it is the general master of all organ networks. Before the heart fire can harmoniously blend with the kidney water, however, the kidney water must be sufficient. Otherwise, the heart fire will flare out of control and all kinds of heart and kidney ailments will arise. Really interesting and very much sounds like the precursor to the slogan from World Kidney Day, doesn't it? I still use this in my CKD talks well over 10 years ago. Protect your kidneys, save your heart. So that you can see that relationship between the heart and kidneys is not new. And then finally, Gentiles de Fulgenio was an influential professor and teacher of medicine in Bologna and in the first part of the 14th century. And he was one of the first physicians to perform human dissection, actually. And he's actually considered to be the modern medicine's Western world's first cardio-nephrologist. In his commentary on De Pulsibus, which translates to About Pulses, he stressed the importance of heart disease on modulating the color and output of urine. So, despite this long-established relationship, there still persist several guidelines published across the whole CVRM spectrum, which largely follow a single condition model of care. Whereas we've heard already from Mimi, from others, that multimorbidity is now the norm. Our conditions, more of our patients have two conditions than one condition. So why do we continue to take this siloed approach to healthcare? Now, don't get me wrong, I appreciate guidelines are an intrinsic part of everyday clinical practice. Guidelines are beneficial by promoting beneficial interventions, discouraging ineffective interventions, and overall promoting consistency of care. But guidelines can also potentially be harmful when recommendations are based on outdated evidence, or more importantly, when they don't take into account an individual's circumstances. So that's why we need a reconfiguration of the delivery of healthcare and indeed education away from a disease-centered approach to a more holistic, person-centered model to improve both quality and quantity of our life and also sustainability of our healthcare systems. And of course, the evolution of pharmacological therapies over the last 5 to 10 years has really helped drive change. The SGLT2 inhibitors, probably the biggest therapeutic advance in my career to date. Well, alongside the GLP-1s and the GLGIP, non-steroidal MRAs as well, such as finerenone. These can be used in a range of CVRM conditions in people with and without diabetes. And we have a number of pipeline therapies that are going to launch with multiple indications, such as obesity, such as MASLD, the new terminology for NAFL, non-alcoholic fatty liver disease. And of course, the GLP-1s and the GIPs are already being used in type 2 diabetes and obesity, increasing evidence for their use in MASLD, sleep apnea, cardiovascular disease. And interestingly, the GLP-1s are also being studied in alcohol dependence, Parkinson's, and Alzheimer's as well. Whereas your non-steroidal MRAs, such as finerenone, are used for diabetic kidney disease, but now also have a license for HFpEF and HFmrEF, heart failure with mildly reduced ejection fraction, heart failure with preserved ejection fraction. So I really love this quote from Sir William Osler. The young physician or nurse or pharmacist, any member of the MDT, of course, starts life with 20 drugs for each disease, and the old physician ends life with 1 drug for 20 diseases. Here are just some of those pipeline drugs I briefly mentioned that are coming our way over the next few years. Really exciting time, but potentially confusing time for us all working in primary and secondary care. But hopefully this will help reduce those silos, break down that siloed working and work in a more holistic fashion. So to finish, really a call to action for us all working in primary and secondary care, what I believe should be core components of high quality and holistic CVRM care. We need to promote a comprehensive assessment of overall CVRM risk, not just individual diseases, including life story, lifestyle choices, and consideration of social determinants of health. And I'll come on to that shortly. Promote a more coordinated, holistic MDT approach to ongoing CVRM care, implementing, of course, those pillars of lifestyle medicine and guideline recommendation medical therapies in an evidence-informed yet person-centered manner. And we need to leverage technology. AI and digital health tools can really help optimize management and facilitate a more precise person-centered approach to the management of CVRM conditions. And finally, our population-based healthcare interventions to promote health equity, importantly, including access to newer therapies. That's a major problem at the moment, particularly access to the incretin therapies for people living with overweight and obesity. And then here's a little bit more about the AI and digital health tools I briefly mentioned. These can really help facilitate that holistic CVRM approach. But as I've said already, we need to be very conscious about promoting health equity and considering those social determinants of healthcare, because we continue to see a widening of health inequalities, particularly access to newer therapies. In the UK, life expectancy varies by almost a decade across England. Healthy life expectancy is more than 18 years lower for the most deprived areas compared to the least deprived areas. And of course, since the COVID pandemic, these health inequalities have continued to widen. So if we don't use our privilege to help those who are underprivileged, we're not going to help anyone, are we? And without patient input, our educational activities risk perpetuating stereotypes and failing to address the diverse realities of healthcare. So that's why we need to involve our patients in education programs. And certainly that's something I've been trying to do a lot, have that lived voice, the person voice on educational programs. This was a lovely paper published a few years ago, our greatest untapped resource, our patients. If we incorporate that patient narrative into programs like today, we can help learners understand social determinants of health, barriers and help develop, facilitate a person-centered approach, and of course, cultivate meaningful relationships with our patients. But as always, we mustn't forget there's no such thing as a sudden heart attack. It takes years of preparation. We must always educate before we medicate. The first step in healthcare is self-care. So lifestyle, the pillars of lifestyle medicine, lifestyle choices, of course, pivotal alongside these wonderful new therapies we have available to us in primary and secondary care. So thanks for listening, everyone. I hope that was okay for you, Raji. Just an insight into the future of what might help facilitate a more joined up approach to CVRM care in primary and secondary care. Thanks for listening, everyone.
Thank you so much, Kevin. That was fantastic. And that was, again, a very good presentation on how a holistic approach, how so many different resources, whether it be artificial intelligence, blockchain, cardiometabolic clinics, all those things that are happening at various places, various levels across UK, Europe, and globally. But Kevin, there are still gaps there, because if you look at the primary care, for example, in the UK, you give so many talks, you do so much of education training across primary care, especially. There are still challenges where GPs don't feel confident in prescribing drugs like SGLT2 for heart failure, or prescribing that other lipid drug for lipid management. What is that one thing that the government can do really? Because we keep going back in circles again and again, and we still see that there are so many newer drugs coming out. There are at least 10, 15 new drugs coming out in the next 2 years in the lipid space. And we are still talking about four pillars of heart failure. The only possibly about 28, 29% patients in the UK get four pillars for heart failure. How are we going to make it better?
That's the $64,000 question, isn't it? We need more resources in primary care. I mean, we're firefighting in primary care. We're asked to do more and more with fewer and fewer resources. So we need, it's not just GPs, is it? We need to use the whole team, that multidisciplinary team. We have practice pharmacists, we have fantastic run long-term condition clinics, PAs, our advanced nurse practitioners, of course, working closely with community heart failure teams, it needs to be a team effort. Primary care can't do it ourselves. And we need to have that bi-directional education as well. I mean, as you said, with all these new therapies, the pillars, I mean, there's no point, is it, having all these new therapies if we're not prescribing them in the first place? So education is pivotal, but that multidisciplinary team approach and that bi-directional educational approach is also important as well. But ultimately, we need a top-down approach. We need more for funding in primary care, for resources to allow us to do chronic disease management, CVRM, risk assessment more comprehensively.
Thank you so much, Kevin. Those are very, very important points. I think that needs to be taken on board by the government, by the policymakers, by the primary society. So we'll definitely include all of those important points that you've mentioned. And thank you so much again for taking our time all the way from the conference and being in the US and still speaking to us. We are very grateful for that. Thank you so much again.
Bye-bye.
Take care. Take care. So on that exciting talk from Kevin Fernando, we are now moved to our next speaker, who is Mr. Uday Bose, who is the head of human pharma, global go-to-market and business steering at Boehringer Ingelheim. Mr. Uday Bose has pioneered lots of interesting initiatives in the last few decades that he's served as country managing director of human pharma, but also worked across different portfolios of respiratory, oncology, cardiovascular, diabetes portfolios. He's also a university alumni of Durham, where he champions customer-centric innovation, equitable access initiatives like making more health a global partnership. So again, he's working on a lot of these exciting initiatives beyond medicine, beyond pharmaceutical world. And please allow me to welcome Mr. Uday Bose as the next speaker. He is going to speak about beyond medicine, the role of pharma in improving healthcare in wider communities, because again, as we have been discussing in the last couple of days, there are several global health challenges which have taken new corners, and we really need to do something about it. So over to you, Mr. Bose, and thank you so much for joining us today.
Thank you so much. Thank you so much. Let me share my screen. If we manage that here. Oops.
You should be able to share in a second.
Let's have a look if that works.
Yeah, it's coming up.
Yeah. Let me just see if I can.
Perfect. We
You're
can.
seeing it? Yeah.
Yeah, we can see it.
I go full screen. You see full screen now?
Full screen. Perfect.
Wonderful. Perfect. Thank you so much. So yeah, thank you so much for the kind invitation to support this incredibly important Global Health Alliance, and the topics are very relevant. I'm going to take a few moments just to give you a little bit of background about the organization, but more importantly, more specifically, the importance of collaboration and shared objectives in terms of what we're trying to achieve for our patients. So the title of the talk, as you can see, is Allies in Action, Shaping the Future of Healthcare Together. Just a little bit about Boehringer Ingelheim. Not many may know the name of the company. It's a traditional family-owned organization, family-owned since inception in 1885. Just over 54,000 employees. We're operating in over 130 countries globally. Industry average for investment of our sales into R&D is just under 20%. We over-invest in R&D. We have a big focus on breakthrough innovation, breakthrough designation, as you know, from the FDA. So 23% of our net sales is going into R&D. We serve 66 million patients globally as of last year's figures. And we are in a period of quite significant launches, with 20 new therapies expected to be launched in the very near future by 2030. Sorry, is it still sharing?
Yeah, you can still share. Can still see. Yeah.
Okay,
If you
sorry, I've
move to the
lost it.
next slide, maybe.
Yeah, it's just I'm not able. I'm seeing your.
No, we can see your slide. You're on the global footprint slide.
Okay, let me
Maybe if you.
let me see if I can. Yeah, I'm not able to. Hang on a sec. Give me a moment.
Maybe you have to reshare again once more, then it should start working.
I think so. Yeah, let's do that. So, content only, share. Okay, let's have a look if this works now.
Maybe you have to stop sharing and then share again, Mr. Bose, then it should work.
Yeah, let's
Again,
do that.
share now and then it should come up.
Okay, I've stopped sharing. So let's.
And then share again.
GHA. Share. Full screen. Okay.
Yeah, we are there.
Okay, perfect. Let me just minimize this bit. Right. Sorry about that. So,
no worries.
Rather than going from the usual side to side, I'm actually going to start with the UN Sustainable Development Goals. We as an organization made a conscious decision to align ourselves with the problems that society is trying to address. And the UN SDG4G goals, as you know, have made that quite clear. There are 17 goals in total. And we, as a company that works in both human and animal health, see a fantastic opportunity for us to be able to focus and support this important endeavor. We've organized ourselves in these three areas. So the first one is more health, which is focused on good health for people and animals. More potential, which is very much, as Dr. Narayan mentioned, the work that we do as making more health in terms of looking for supporting communities and vulnerable populations. And more green, which is probably more of the traditional things that we hear about and talk about in terms of environmental impact. And you can see the priority programs that we have, of which I will focus on one in particular today in the area of chronic kidney disease, are very much aligned to those goals. So on the next slide, I can give you a little bit more detail in terms of how are we performing against those objectives. So we have set targets by 2030. These are the global targets that we've set to reach 50 million people through the social engagement work that we're doing. So these aren't the people that are typically targeted through interventions, but actually proactively working with social entrepreneurs and communities to be able to address healthcare challenges that are happening at a local level. Of course, we have a number of environmental targets as well, which have been described here. As a UK and Ireland organisation, we've already, in our organisation, got 100% renewable energy supply now, significantly reduced our operational emissions. In the area of animal health, we've issued 17,000 additional free tests for equine Cushing's disease, which is a devastating disease in the equine in horses, and of course donations to charities that we've been working with. We've moved up the Access to Medicine Index quite notably over recent years to the position of 8th, which we are pleased with. Now, bringing it home in terms of UK and Ireland, as I said earlier, it's very important we as an organization align ourselves with societal topics, with societal problems. Many years ago, when I started in the industry, it was quite a traditional model where we would go to a market with a product and seeking to position the product. We recognize now we have to consciously, proactively work with the healthcare system to enable innovation to reach patients. It's not just about bringing the innovation. We have to work with the system to be able to ensure access, because that's why we do what we do. So we've looked at the 10-year NHS plan, and it's interesting and important to note that irrespective of the different prime minister that we have and the different government that we have, the commitment to the NHS and the NHS plan is somewhat politically agnostic. And the 10-year plan is very important because it gives you a longevity, it gives you a perspective for a longer term, where so many of the programs that we're working in are not going to give you an annual return. It's actually a longer term commitment that you have to make. The areas that we focused on within the 10-year NHS plan, where we see a strong alignment between our current and future portfolio and the objectives of the NHS plan, as you would expect in the first area, CRM, cardiorenal, metabolic diseases, and chronic kidney disease, and specifically in the area of screening, prevention of these diseases and screening. Accelerating the updated service specification for interstitial lung disease. For those of you who are close to this topic, you'll know ILDs are increasingly prevalent, and in terms of their impact on patients, can be as severe and devastating as cancer. We have, speaking of cancer, a national cancer plan for England, and again, we are strongly and closely aligned to that. And a very important area where we continue to have a focus is, of course, parity in the area of mental health. So these 4 areas we are prominent in the NHS plan, and thereby prominent for what we are doing. Now, specifically in this last part of the presentation, I wanted to focus on the area of chronic kidney disease and this burden. And what we have noticed is, and you're not meant to be able to see the details on the slides, on the 3 images there. I would encourage you to take a look at our website for boehringeringelheim.co.uk, where you will see a lot of details around these projects, as well as videos from both patients, payers, healthcare professionals, and others in terms of the collaboration that I will briefly describe. I think there's clear acknowledgement there is system transformation required, and Dr. Fernando earlier spoke about this, as did Dr. Narain. It is stunning, actually, in a country like ours, how significant the disparities are within local populations even. The Renal Services Transformation Project has been initiated to help identify and address these topics of the need for transformation. A lot of work needs to be done in terms of raising awareness. A lot of patients, as you know, are not aware that they have chronic kidney disease until it's quite advanced. And therefore, awareness of symptoms and awareness of the importance of screening for CKD is incredibly important. And the program that we've been working on with the NHS has led to significant improvement in awareness and raising the consciousness of the disparities in terms of provisions and outcomes, because obviously those 2 things go hand in hand. Now, we're working on a program called SPOT, Screening, Prevention, Outreach and Treatment for Chronic Kidney Disease in Underserved Communities. And this program has been initiated in partnership in 2 localities. So we started in Hampshire and the Isle of Wight to really enhance the screening of CKD for the local population. The concept here is to pilot a project in partnership closely with the NHS in an area where we can show the opportunity, we can learn, but also we can show the impact, and then use that as a basis from which we can scale to the rest of the population. So in the next slide, I'll give you a little bit more detail in terms of what we're doing with this particular program. So for the UK and Ireland, the organizations that we support, this affiliate, this has been a significant effort that we've made. So the NHS Challenge, you've seen these figures earlier today, 7 million people in the UK have chronic kidney disease, and early detection and awareness is critical. We know that access to care is generally low, and there are certain demographic groups that have particularly poor access to screening and, of course, treatment beyond that. NHS organisations in England, we know, are overwhelmed. The waiting lists are significant, and the demands placed upon our wonderful NHS are only increasing. and the inequities are only seemingly also increasing. So this is an area where there is a significant challenge for the National Health Service, where we need to be able to work with them to support them. Scope of the project is quite clear. We have 4 specific work streams. One, of course, is going to be around the pathway. So the chronic kidney disease pathway creation. Linked to that, of course, is the identification of patient, case findings and diagnosis, really understanding through cases what is the reality of the patient demographic that we're looking to support. What is their reality in terms of healthcare access, access to screening, access to ongoing support, and thereby design a service that is better tuned to their needs. Of course, treatment, management and monitoring of these patients in this pathway is also critically important. And finally, the 4th work stream is around healthcare professional and patient education and awareness. There is a renal advisory group in place, including the National Clinical Director for Renal Services Transformation Programme, NHS England, and we work very closely with them to continue to provide support and get their input. Now, I think this is one of the benefits of working with a commercial organisation like ours, where we tend to very quickly focus in on the outcome. So there's an investment. What is the impact? What is the outcome going to be? And I'm really proud of the approach that the organization takes, which is rather than imposing our outcomes onto the project, we actually co-create and collaborate with the NHS in terms of what are the outcomes that would be meaningful for frontline care, but also in terms of system reform and the transformation that we're looking to achieve. So of course, actionable blueprints are going to be important. If we're going to run something that we want to try and scale beyond, it's very important that the details are captured that enable scaling to happen. We know that this is an Achilles heel of us in the UK and in the NHS of scaling programs. Improving the quality and access to care is, of course, something that we can measure, that we can put key performance indicators on the back of. Often it's a lack of data, it's a lack of information that we struggle with. We have a lot of data, I should say, but it's a lack of accessible data to make decisions. So developing the local dashboards to monitor that care is another critical outcome. And again, that would be something that could be scaled, but also looked at from a national perspective. Ultimately, we are looking to, of course, decrease health disparities and health inequalities and increase the rates of detection through effective screening. We are, of course, are looking at the outcome of reducing the progression of CKD. The more patients we can prevent from advancing in their disease in terms of accessing more significant care, dialysis, for example, the better for the patient primarily, but also therefore, obviously, for the system as well. And that links to decreasing the CKD-related complications. And of course, linked to that is the reduction in referrals. So that's where I was going to leave the presentation. As you can see there, we have a QR code there, which you can access in our website. And we have a number of videos and additional information there. Joint working is critically important for us as an industry, but also with the NHS. So joint working is an area where we, as I've just described there with the SPOT program, that we identify an area we can align our objectives. Now, we are a very heavily regulated industry globally, but of course here in the UK as well. And when we do a joint working agreement, it's very important. There's a lot of transparency around these topics. So we have, you'll see on our website, you will see explicitly what are the terms of the joint working agreements, what has actually been agreed, who does what. We're very mindful of the sensitivity of data, and you can find information about how we manage data and protect and adhere to GDPR as well. So I would really encourage you to take a look at the work that we're doing, but also other companies in this space. Collaboration is the key to our success, and I'll leave it there and hand you back. Thank you so much.
Thank you so much, Mr. Bose, for that exciting talk. And obviously, you talked about and touched so many different initiatives that BI is leading in the cardiorenal metabolic space. But if you look at the global burden disease data, heart, kidney, diabetes, cardiorenal metabolic are going to be in the top 5 causes of death in the next 5-10 years. If you look at the numbers here in the UK, we almost have about 8 million patients with CKD. Almost 10% of UK's population, for example, has some degree of CKD. We have already hit 823 million plus patients with diabetes globally. We were supposed to reach 800 million in 2055 or 2050. We are in 2025 and we've already hit 800 million. So, we are doing, and again, companies like yourselves are doing whatever is possible to stop that disease progression, and obviously bringing all those important drugs like SGLT2, for example, in CKD, in the heart failure space. But don't you think that the time has come for working together, as you rightly mentioned in your presentation, that we need to join forces? For example, can there be an initiative where all the pharma companies who are working in the cardiorenal metabolic space, they join hands together to create that awareness globally in the UK, in Europe, and globally, and work with the government more closely?
No, it's a great observation, and it's actually quite common, and it's a great opportunity for me to emphasize that. So I think there's an expectation that there's a lot of competition within this space, but actually on these macro topics, on these global health societal topics, there is a significant amount of collaboration, and there needs to be. I think you saw recently, we all saw with the pandemic, which was a crisis, admittedly, but that was an amazing example of where companies actually came together because of the situation, and the urgent situation demanded it, whether that was giving access to manufacturing and vaccine production, whether that was collaborating in terms of science. And we are seeing this happening in the space of cardiorenal metabolic diseases. So ourselves, for example, AstraZeneca, here in the UK, you will see a number of projects where actually we're working in sync and trying to avoid duplication of efforts, but rather actually looking to combine our efforts wherever we can at a macro level. And I think that's where the NHS is so important, because partnering with the healthcare system is so important in terms of transparency and legitimizing why we need to make that effort. So yeah, long may it continue.
Thank you so much again, Mr. Bose, for all those important points that you touched on. We'll definitely make